the practicing pediatrician. With great pleasure, we welcome one and all. And I request Dr. Kannan sir, President of IMA Mehta, to kindly render the welcome address and inaugurate the program.
Now, good evening, Kannan sir. Are you there, sir? Kannan sir, can you hear us, sir? Good evening, sir. Sir, I think you're mute, sir. Please unmute yourself, sir. சார் ஆமா சார் நாங்க பேசுறது கேக்குதா சார் உங்களுக்கு?
போன்ல கேக்குது, நீங்க பேசுறது கேக்கலையே. அன்மியூட் பண்ணிட்டேன். சரி, இப்ப நீங்க ஆரம்பிக்கிறீங்களா? நான் ஆரம்பிக்கிறேன். நீங்க 2 வார்த்தை பேசுறீங்க.
Good evening again. I think everyone is online now. On behalf of Mehta Hospital, we welcome you all to the CME session today. We also welcome the IAP TNSC office bearers who have agreed to join us. Thank you, sirs. I'd like to start the session by inviting Dr. Kannan sir, Medical Director of Mehta Hospital, as well as IMA Mehta President, to say his words of welcome and to inaugurate the CME. Sir, please.
Thank you, Shivan. Good evening to you all. It's a matter of great pleasure and pride that Department of Pediatrics is organizing the CME for the benefit of practicing pediatricians. We went through the itinerary. It is very interesting and it is very topical and it's going to be very useful to all of us. On behalf of Dr. Mehta's Hospital and on my own behalf, I welcome the office bearers of IAP, Tamil Nadu State Chapter, who are very actively involved in all the academic programs throughout the state, but for whose help this program would not have been feasible. I welcome you, sirs. I welcome the distinguished faculty who are assembled here to give the lectures. I also welcome all the delegates who are eagerly waiting to listen to the speakers. Let us all benefit by the combined knowledge which is going to be showered by the speakers. Thank you very much.
I now request Dr. Sharda ma'am, Secretary of IMA Mehta, to say a few words.
Good evening, everyone. On behalf of IMA Chetpet branch, I welcome one and all for this happening CME. The viruses are fighting with each other to infect us. And one has sort of going off and the next virus is entering inside. And we need to understand what is happening and about the tropical infections, which is going to be the which fight among themselves, like along with our old enemies like dengue and typhoid. The topics which are being presented in the CME would be of great help to all the practicing pediatricians. So I welcome the office bearers of IAP Tamil Nadu State Chapter, as well as the faculty and the delegates to deliver the great session. Thank you, everyone.
Thank you so much, ma'am. I now request our IAP TNSC President, Dr. Ismail sir, to say a few words.
Sir, are you there, sir?
He is not there, Shivan. He's not there.
Hi.
Maybe you invite Dr. Rajendran.
Yes, sir. Jyotsna?
Yes, sir. I invite Dr. Rajendran, sir, Secretary of IAP-TNSE, to say a few words.
Thank you, Doctor. On behalf of IAP-TNSE, I welcome one and all, and respected our President, Dr. Ismail sir, and Dr. Nedunjalin sir, and seniors like Gauri Shankar, and organizer faculty, Dr. Kannan, and our academic head of the department, Dr. Tangavelu sir, and Vijayaraghavan sir, and LK Prem Kumar, and Sivan Kesavan, who is going to organize the event, and our Treasurer, Dr. Kapal Subramaniam, other dignitaries and faculties. And again, on behalf of IAP-TNSE, really appreciate that effort taken by our Mehta EMA and Mehta Children's Hospital to teach and educate the practicing pediatrician. And as our present action plan, we are doing appeals for practicing pediatrician. Our President, Dr. Ismail sir, is doing. And it's a well appreciated program for all over Tamil Nadu. So in this context, I really appreciate our Mehta faculties to take initiative for educating and enlightening the importance day-to-day problems in easy manner to all our practicing pediatrician. And I once again thank our organizing team for this wonderful opportunity. Thank you, Ananda. I think Dr. Ismail sir is there. Dr. Ismail first, yeah.
Yeah, good afternoon, all of you. Sorry, there is an instability in my internet connection. Anyhow, Dr. Kannan sir from Mehta Hospital, Dr. Tangavelu sir, the program coordinator, and of course, my friend Gauri Shankar, Rajendran, Gopal, and all organizers and the faculties today. Hope it's a wonderful program for the practicing pediatricians. All these 2 years went after COVID. So a lot of webinars on COVID, CMEs on COVID, everything was based and biased on COVID. Now I think we are slowly coming out of that. And I think really we have started helping the pediatricians. I went through the itinerary. It is really good, especially latest achievement, treatment and management of enteric fevers, and of course, usage of IVIG and the latest care, the Nipah virus, everything has been covered nicely. I think the practitioners will be having a very great time in this, and I wish all a happy learning. Thank you.
Jyotsna, you have to unmute yourself.
I welcome Dr. Gopal Subramaniam, sir, Treasurer of IAP-TNSE, to say a few words.
Thank you. On behalf of IAP-TNSE, I congratulate the team for bringing out this wonderful program for practicing pediatricians. All newer programs and newer things we are doing, and I really appreciate the Mehta Children's Hospital, especially Dr. Kannan sir, Dr. Tangavelu sir, Nedunjalin sir, and Gauri Shankar sir for bringing out such a wonderful program, which will be very useful for the practicing pediatricians. I wish the program a grand success. Thank you.
Thank you so much, sir. With this, we'll be moving on to our scientific session. We call upon our first speaker, Dr. Erythromycin ma'am, to deliver her talk on IVIG prescription for the practicing pediatrician.
Good afternoon, everyone. I thank the IMA Mehta Chepet and IAP-TNSE and our pediatric department, my own pediatric department of Mehta Hospital for giving me this opportunity. Actually, initially, when they asked me for a topic, when they asked me to choose a topic, I thought IVIG. I took it thinking it's quite an easy one. But then last couple of days, I've been fascinated, like the famous Tamil dialogue. In a path odane pudikadu, like IVIG is very expensive. I never used to like the drug, but Paka Pudikam. So when I started reading a lot about IVIG, it's so fascinating. Like I can even do IVIG 1, 2, 3, 4 series, I think, like a Netflix series. So it's such a fascinating molecule, and the last 5 days has been eye-opener for me on these drugs. Shivan, can you share my slides, please? Shivan?
Yes, ma'am, I'm doing it, ma'am. Just a second.
Yeah, thank you. So I'll just spend a few minutes on what exactly is IVIG, because such a fascinating molecule. For us, we need to know, I'm not going in depth, but just to know a little about immunoglobulin so that we understand. See, this is actually what is immunoglobulin? It's actually an antibody. So we give it in infections, that is, we're providing antibodies to fight the infection. At the same time, they're also used in a lot of inflammatory disorders and in autoimmune disorders when there's an excess of antibodies, in which case it's actually autoantibodies. It's like a two-edged sword. How come we are using it as an antibody, also using it the other side when there is a lot of excess antibodies, though it is autoantibodies. So such a fascinating molecule. So immunoglobulin, next slide soon. The basic structure, see, it's actually immunoglobulin has a heavy chain. The H is the heavy chain, which is a longer one, and light chain. And functionally, they are separated into a variable portion, that is V. No, the variable portion, which is the terminal one. That is the V, which is marked as V. VL is the light chain variable portion. VH is the heavy chain variable portion. And then you have a constant portion, domain. So what is the difference between the variable domain and the constant domain? Why we need to know it is, see, the variable domain is where the antigen gets, or the antigen binding sites. So that is where your antigen binds and it stimulates the various immune responses. And then what happens, the other one is the constant portion is actually if you see that, if it is FC fragments. So the antigen binding fragment contains the entire light chain and the entire variable portion of the heavy chain and a small portion of the constant component or the domain of the heavy chain. So that is the FAB, the V-shaped one on top, and which is connected by the hinge region. That is exactly where the antigen comes and sits, stimulates these immunoglobulins and produces a response to the antigen. So how does the response occur? How does that function occur is through the FC fragment. The constant fragment of the heavy chain contains a constant fragment of the heavy chain. They attach to FC fragment attaches to FC receptors and causes the effect of functions. We're just going to do later into how exactly, what are the various ways it affects the stimulation will bring about a response. Next slide. So then just a few terminologies. So some of them were pretty fascinating, like the idiotypes. Paratopes are sites on the immunoglobulin where the antigen binds. The next slide, please, Shivan, that has a picture, that will be easy. Yeah. So the paratopes are the sites on the immunoglobulin, the antigen binding sites where the antigen actually goes and binds. The red ones, that is the paratopes. The epitope is part of the antigen that binds to the antigen binding sites. The fascinating thing that I learned about while reading this is the idiotype. What is an idiotype? Because a lot of things have been happening with the idiotypes, a lot of things coming like anti-idiotype antibodies. So these will be the therapy of the future. So immunoglobulins in vivo are produced against antigen which are in soluble forms. This is in vivo. So how do they identify surface epitopes? Epitopes are the sites on the antigen or the viruses or the bacteria which stimulates the antigen binding sites. How do they recognize? They recognize non-contiguous sequences, not just the entire sequence. They can also identify parts of the sequence. So that is how they are able to identify antigens, even which are closely related. They are able to distinguish. So such a fascinating molecule doesn't just the entire sequence, it doesn't, on the antigen, it doesn't recognize, it actually recognizes the various individual components of the antigen. So that is how even closely related antigens are, they are able to discriminate. The other thing is, if some of the antigens, diverse antigens share a few epitopes, they are still able to cross-react with them. That is where your cross-reactivity comes, both in the cross-reactive antigens. So that is how certain tests also becomes false positive, cross-reactive antigens. So idiopathic and idiotypes are, or in other words, these are antigenic determinants of the immunoglobulins, which are present in the variable portion of the heavy and the light chains. So the lot of researches are going on now, because anti-idiotype antibodies directed against these idiotypes are being done, and under physiological conditions, we have talked about complement cascades, we have talked about other cascades, but it was a little new to me. See, whenever an antigenic stimulus occurs, there is a cascade of idiotypes. That is, idiotypes are part of the immunoglobulin. At the same time, anti-idiotype antibodies are produced at the same time. This is very crucial in immune response to external as well as to self-antigens. So when you manipulate this production of autoantibodies, that is anti-idiotype antibodies, that is the cause of various autoimmune diseases. So in susceptible subjects, when their idiotypes are stimulated, they also form anti-idiotype antibodies, which over a period of time eventually lead to the development of autoimmune disease. This itself is an antibody. Anti-idiotype antibody is an antibody which attaches itself to the idiotype of the immunoglobulin. So how complicated a process this is. So anti-idiotype have therapeutic implications. See, the immunoglobulin, the IVIG that we have, that we take. So even in our body, there are a lot of small quantities of anti-idiotype antibodies. As I said, when the antigenic stimulation occurs, it stimulates the idiotypes to produce even anti-idiotype antibodies. So there is a small fraction of these anti-idiotype antibodies in the IV immunoglobulins that we prepare, which is pooled from a lot of people. And this actually helps us in treatment of autoimmune diseases. Next slide, please. So let us go into what are the various isotopes. Isotopes are nothing but subclasses of immunoglobulins. So the IgM. So this IgM is the first to be expressed during B cell development. The first of the immunoglobulin that is expressed during B cell development. So the naive B cells expresses what is called a monomeric IgM, which on maturation and antigenic stimulation becomes multimer. This monomeric IgM has actually a very low affinity, and due to their immaturity, they're actually natural antibodies. They are not formed by external stimulation or by any vaccination. These are called natural antibodies, and these are the first line of defense against any infection. So how does IgM function? IgM functions by opsonization, that is coating the antigen for destruction. So the first step in destroying any pathogens is coating them so that it can be either through macrophage activation or through complement activation, they can be destroyed. So the opsonizing effect is done by IgM, and then they fix the complements. Then the next is the IgG. So IgG is the predominant isotope which has the longest serum half-life. Actually, IgG, there are, depending on the structural, functional, and antigenic differences, actually we have 4 subclasses. What we do not have facilities to here, but there are some institutes like PGI Chandikar which actually does subclasses. So we have 4 subclasses of IgG, which is G1, G2, G3, and G4. Why they are put 1, 2, 3, 4 is depending on the serum levels. Ig1 is more than Ig2, which is more than Ig3, which is more in a normal, healthy individual blood. So there are differences. The final way that they produce an immune response is by activation of the complement cascade. So except G4, all other G1, G2, and G3 fixed complements. That is how they bring about a response. That is the effector response of these. So the other things is G1 and G3 are produced in response to protein antigen, whereas G2 and G4 are produced in response to polysaccharide antigens. These IgG is actually a secondary antibody response, whereas IgM is our first line of defense. These different subclasses are also important in various diseases like HIV. In HIV, IgG3 is more effective in neutralizing the virus than 1, 2, and 3. And in certain dermatological conditions like pemphigus vulgaris, see, this pemphigus vulgaris is because of antibodies to desmoglin 3. So various studies have shown that IgG4 antibodies are pathognomic, whereas IgG1 autoantibodies to the same protein in the family members do not show any active disease. So there is functional difference between even these 4 subclasses. I think over a period of time, more and more studies are coming in the pathology, treatment options, targeted therapy. I think we will still go into the depths of studying G1, G2, G3, and G4. Next. So the other 2 immunoglobulins are the IgA and IgE. IgA is, as you all know, is for protecting the mucosal surfaces. The IgA levels are more than IgM in the normal serum, but it is much less than IgG. Whereas in the saliva or the breast milk, obviously this is a secretory, so protects the mucosal surface. So in the saliva and in breast milk, it is predominant. Again, you have 2 classes, subclasses, IgA1 and A2. A1 has a more longer hinge, so it is more prone to destruction by bacterial proteases. So in the secretory, it is usually IgA2, whereas because the bacterial proteases presence in the secretions destroy A1, so then they're not stable otherwise. So whereas in the serum, it's predominantly A1. And IgE is more involved in hypersensitivity and allergic reactions. So let us go into next slide, please. So basic mechanism by which they act, that is the effector response. The first step is antigen binding. The next step is effector. How do they act? As I said, the FC fragment, FC portion, FC, there are a lot of FC receptors in macrophages, most of the hematological cells, where they attach and they release a lot of cytokines and pro-inflammatory mediators. These play an important role when we come to treatment of severe forms of infections in inflammatory conditions in Kawasaki's. They also have a T cell mediated, they cause programmed T cell activation and or death, depending on the conditions. And they on B cells, they downregulate the B cells. The immunoglobulins downregulate the antibody formed by the activated B cells and also directly neutralizes pathogenic antibodies in autoimmune diseases. So then the dendritic cells. Dendritic cells are important for T cell activation. So IVIG, when given in large doses, will inhibit dendritic cell differentiation, which inhibit expression of CD80, 86, and HLA, which further which is important for T cell activation. Next slide, please. They also, the immunoglobulins also have an action on cytokine productions. As you all know, Th1 cells and Th2 cells are involved in production of inflammatory pro and anti-inflammatory cytokines. So there is a disturbance in the balance between Th1 and Th2 cells in autoimmune diseases in which Th1 becomes more prominent. So IVIG that we give has antibodies against the Th1 cells. So by suppressing, it sets back the imbalance, and that's how one of the mechanisms by which it acts in autoimmune diseases. They also complement activation. This is, they bind to activated C3 and C5 and decreases complement activated cellular damage. And they also, as I said, they also behave like anti-idiotype antibodies. Next slide. So what is an ideal immunoglobulin? Just as about the basics. So now what is an ideal intravenous immunoglobulin? They are usually, donor should be at least 4,000. So we have pooled donors. So the number of antibodies that they are going to have is going to be a little more. And the half-life should be longer than 20 days. monomeric IgG must be higher than 90%, and there should be appropriate like subgroup distribution. So IgA particularly should be very low, less than 40 milligrams per liter. And FC function should be complete, because that is how the effector response of the immunoglobulin is done. And obviously any preparation should be pyrogen free and there should be no aggregates. Next. So what are the gross ways that there are a lot of Sarvaloga Nivarani is what even intravenous immunoglobulins. We have used immunoglobulins for a variety of different conditions. So broadly, we can classify them as replacement indications, anti-inflammatory or immunomodulator effect, where we use intravenous immunoglobulins. Next. So the main thing, the therapy is for primary immune deficiency. So primary immune deficiency, the dosage like CVID, SCID, the dosage recommended is 400 milligram per kg every 3 to 4 weeks. Only thing to make sure is you've done the baseline investigations and the immunoglobulin levels before you start on replacement, because once you give you alter the levels of the immunoglobulin. So preliminary investigations, confirmatory tests to be done before giving immunoglobulin. Then in HIV, where there is associated deficiencies, in CME children, younger children who apart from specific therapy, they are all known to have recurrent respiratory infections in the initial infant period. A lot of studies, and our own PG has done a thesis on CMV and proven that a replacement with IV immunoglobulins in these children reduces the recurrent respiratory episodes in these children, and over a period of time, by 1 year, they outgrow the infection. And in nephrotic syndrome, yes, we have done a lot, and we still do even in our department. See, nephrotic syndrome children lose immunoglobulins when they lose proteins in the urine, and they are prone to recurrent peritonitis. And every time there is an infection, there is a recurrence or relapse. So IVIG as a replacement, immunoglobulin as a replacement is not specific therapy for nephrotic syndrome, but we can keep the infection rates to a minimum as an adjuvant therapy to the specific therapy for nephrotic syndrome. Next. Then the fascinating role of these as immunomodulators. So the maximum usage is in immune thrombocytopenic purpura. The present recommendation is 0.8 grams per kilogram body weight given over 1 day. See, platelets are destroyed in the spleen in immune thrombocytopenic purpura by FC receptor binding bearing phagocytic cells. As I've already told you about the mechanism of action, IVIG has this FC fragment which will bind to the FC receptor and competitively inhibit the platelet destructions in these children, bringing up the platelet levels. And the next indication, commonly used indication, is Kawasaki's disease. Here the dosage is 2 grams per kg as a single dose, or 1 gram per kg over 2 days. So early, as you all know, indication in Kawasaki to be given early for better response. Here, the mechanism of action is immunomodulatory. One, reversal of the, it is an autoimmune disease or inflammatory disease where the lymphocytes are activated and it stimulates apoptosis. This IVIG inhibits lymphocyte apoptosis, and there has also been studies that shows they have inhibitory effects on platelet adhesion and thrombus formation by acting on von Willebrand's factor, and also causes neutrophil apoptosis. So these are inflammatory conditions when neutrophils play a major role. By apoptosis of the excited or activated neutrophils, you bring down the inflammatory response. And the third most common case in pediatrics where it is widely used is Gulen-Barre syndrome, where it is given in a dose of 1 gram per kg. Again, here the role is neutralization of as you know, the pathogenesis of Gulen-Barre is anti-ganglioside antibodies. So neutralization of anti-ganglioside antibodies by IVIG is the mechanism by which it acts in Gulen-Barre syndrome. Next. So we have red indications and blue indications. Red indications I've already told you. Next are the definite indications. So there are even toxic epidermolysis, toxic epidermal necrolysis where it is used, and autoimmune encephalitis where it is red indication or high priority indications. There are other indications. Next slide, please. which are blue indications are there are reasonable and evidences in these conditions that works, but they are probably not the only or the first line of therapy. So there are other states like a preterm with severe sepsis, very sick child on high-grade antibiotics still not responding. Then, as I told you, nephrotic syndrome. In hematology, acquired aplastic anemia, though there are other treatments available, yes, IVIG has been used in, has studies showing the beneficial effects of IVIG in warm autoimmune hemolytic anemias, in hemophilias where they develop inhibitors, clotting factor inhibitors, anti-factor VIII inhibitors, it has been used, and HLH syndromes, yes, lot of studies showing, because though HLH is steroids and etoposide, with the low count, with sepsis, the etoposide is sort of a very risky drug to give. So a lot of studies showing that IVIG have been shown.
2 more minutes, madam.
Yes, next. Next. So in infection, the present things that IVIG has been indicated is in dengue and COVID-19. Again here, it is only indicated, it is not the first line, it is only indicated in severe dengue with refractory shock and organ dysfunction as a rescue therapy, and in COVID-19 when they have severe MIS-C or Kawasaki-like presentation. Next. So the infusion rate, see now 5% and 10% solutions are available. So initially you would start with a smaller, and every 30 minutes increase it. In a 10% solution, which is 10 grams in 100 ml, you can go up to 3 ml per kg per hour. In 5%, you can go up to 6 ml per kg per hour. Next. So the side effects are not, but needs to be monitored. Headache, chills, and myalgia, when you can use antipyretics at the onset of infection. Tachycardia and hypertension to be watched out for. Asymptomatic meningitis is quite a frequent thing which needs to be followed up. Rarely we have thrombosis and reversible renal impairment. So these have to be properly hydrated before giving IVIG. Next. So these are the various preparation available in various strengths. 10 grams, the only advantage of 10 grams is the cost. 5 grams and 10 grams, the cost is almost the same, about 12 to 18,000. So you can cut down the cost by 50% if you can use a 10 gram preparation. Next. So what are the very special situations that, meaning what are the situations in which there will be a problem, like a child on dialysis on plasmapheresis? When do we give IVIG? Usually after that day of pheresis or after the dialysis, you give the IVIG, and the next sitting of pheresis or dialysis, it can be pushed to 48 hours. Otherwise, you will be removing out all the transfused IVIG. In selective IgA deficiency, can develop severe anaphylactic reaction, but now the preparations contain less than 400 milligrams per liter of IgA. So usually it's not with the first transfusion, it's with the subsequent transfusion when they develop IgG against IgA. So be careful when given selective IgA. And then about vaccinations. So after IVIG, ideal thing is to give live vaccine after 8 months of IVIG. But what would you do in a child who's on replacement every 3 to 4 weeks for a primary immune deficiency? You can't wait for 8 months. Anyway, live vaccines are not indicated in these children. So if you have to give, it is better to give within 14 days, if to give after 14 days or at least 1 week prior to giving the IVIG on children other vaccination like killed vaccination. And if IVIG had to be given after a live vaccination, say a 9-month-old child was given a vaccination and on the 10th day developed a Kawasaki and you were forced to give, repeat the vaccination after 2 weeks after IVIG, or if you can push it up to 8 months. So later on has to be the same live vaccination has to be repeated. I think I'm done. Thank you. I'm ready to take up question 1 minute. Let me see chat box.
Yes, ma'am. Ma'am, thank you, ma'am, for the very engaging talk. We have a few questions, ma'am. I'll just read it out to you.
Yeah, I just saw it.
Yes, ma'am.
The first answer recommended is 1 gram per kg, but Shivam, if you want to contradict me on GBS.
Ma'am, I'll just read the questions because people.
Yeah, is it 2 gram or 1 gram per kg now? IVIG in GBS, I thought you will be a better person because references say 1 gram per kg, but we've also given up to 2 grams. What will be your take on this?
Ma'am, generally 2 gram per kg is the dose. We give it over 2 to 5 days.
2 days?
Yes, ma'am. Yes.
Because the references which I saw said 1 gram, so I was also confused. The next question says, any specific reason for selecting red and blue colors for the various indications? Red is absolute indications where they are the first line and they are probably the best, the first line of therapy. The blues are adjuvant. They are not probably if you have other drugs which are more, you would probably go in for that, but they are not contraindicated in those conditions. And comments on giving a single dose versus divided doses. Replacement is usually single dose, which is 400 mg per kg, whereas now single dose has been given. I think single dose versus divided doses, we've not seen a major difference in the response. If it is 2 grams, we split over 1 day, give the entire thing over 24 hours or split over 2 days. We've not seen any major difference in the response. Usually the response occurs 24 to 48 hours. So probably giving over 48 hours or over the same day is, I think most studies need to be done. The advantages and disadvantages. Any precaution with reference to blood transfusions? Better not to give it at the same time, because anyway, the blood transfusions, the febrile reactions, the reaction, because this is also a blood product. As you know, these are pooled multi-donor plasmas. So already you are exposing the child to a variety of antigenic stimulation that can cause a initial and late reaction. So better not to give it immediately or at least a gap of 4 to 6 hours before you want to transfuse a child, either before or after.
Thank you, ma'am. I think you have answered all questions in the chat box quickly. Ma'am, I had one more question before we wind up the session. Ma'am, yes, IVIG, among all the immunotherapies which we have, probably IVIG is the safest, and that's why it is widely used. So I just want to know, ma'am, are there any adverse effects seen in your practice or theoretically which you should watch?
As I said, we've had aseptic meningitis in quite a few children. And there was one child, I think you were not there, you went to do your super specialization. A child from Andhra who's on replacement therapy for almost like 4-5 years, came back with hemiparesis. He had a thrombus. So that day the child had nausea, vomiting, as due for an IVIG. They just went, because subsequent doses, they just give it over 4 to 6 hours, no? Because they've been given over. So usually initial doses and subsequent doses, you're allowed to give a little more faster, because once you know, they're not much of a response. So this child was probably dehydrated. On top of that, this IVIG, as I said, it can trigger off a thrombus. So that was one thing that we had, but the most major side effect is the cost that we encounter all the time, because it's such an expensive drug. And only one thing which I forgot to mention is the presence of immunoglobulin in intramuscular loop. That's a very cheap one. It is available. It is called bar globulin. It is available as 16.5% injections, but only thing, it's an oil preparation. It is very painful. 1 ml contains 100 milligrams. So we were been using this in some of the immune deficiency child, because every 3 weeks immunoglobulin became very tough. So we are still using, but only thing, as they grow up, the volume that we have to give becomes huge and it's quite painful. But the cost is like very cheap. I think each vial is only about 1,000 odd rupees. So the cost is, initially there was a lot of, even in the hematology group, we were not willing when we said we were treating primary immune deficiency with IM Barglo, but we are still having a lot of children who cannot afford it, and some of them are on IM Barglobulin. We avoid it in very small children because it's quite painful, when very big children, because the volumes we need to give is huge.
Thank you.
Prem, I have no idea about IVIG. Nipah itself is a new one to me. You will have to update me on it.
No. I thought once you say it, I'll add it in my current treatment, ma'am. That's it.
No, see, again, if Nipah is also going to have, like COVID, some other inflammatory, post-inflammatory, there are studies showing inflammatory damage because of cytokine storm. See, this is again an anti-inflammatory immunomodulator drug. So Nipah also progresses to something like that. Respiratory distress, if you can prove, is because of cytokine storm or cytokine inflammatory effect on the lungs, then yes, IVIG will definitely have a role.
Thank you, ma'am. Thank you for the answers and thanks for the time, ma'am. If there are further questions, we'll forward them to you. You can answer it at a later time.
Yeah,
Thank you.
Thank you, Shiva.
Next, we move to the next speaker, Professor Annamalai Vijayaraghavan sir, who's going to speak on enteric fever and its updates in diagnosis and management. Dr. Professor A.V. sir is a senior pediatrician and the head of academics at Mehta Children's Hospital in Chennai. So I welcome you, sir. You can start sharing your screen and start your presentation.
Can you see my screen?
Yes, sir. We can see you and clear you. You can go ahead, sir.
Thank you. Thank the organizers for giving me this opportunity to speak on management of enteric fever, update on diagnosis and treatment. Enteric fever is a very common problem which all the general pediatricians and others face. And even during COVID, and even after COVID also, we may be facing this problem. And this talk is mainly to tell about, everybody is very familiar with the enteric fever and its management, and to stress mainly on the resistance of the organism to the drugs which we are using now, and about the multi-drug resistant enteric fever, extremely drug resistant, because part of the treatment is making everyone aware, including all the practitioners, about the resistance to the organism, to the drugs. Enteric fever mainly caused by Salmonella enterica, serover type typhi, and also to a lesser extent by S. paratyphi A and B, very rarely by C. Humans are the only reservoir for these organisms. The main source of infection are stool and urine of infected persons, with the important vehicles being contaminated with water, food, and flies. The incidence is a major public health problem, particularly in low-income countries of Asia, Sub-Saharan Africa, where majority of the population strive for the safe drinking water, limited sanitation, and hygiene infrastructure. It is estimated to cause 11 to 21 million illnesses, 1.28 to 1.61 fever deaths annually throughout the world. In India, the incidence is about more than 60 lakh cases per year. In one of the studies using blood culture, it was found that the incidence was 451.7 per 1 lakh per year in Karachi, 214.2 per 1 lakh per year in Kolkata, and 15.3 per 1 lakh in Hechi in China. This actually shows the endemicity. We are in the very endemic area, India, Pakistan, and neighboring countries, and sub-Saharan. Age-wise incidence, children below 15 years are more susceptible, probably because the adults have developed immunity from the infection or subclinical cases. Study from India reported most cases occurred in children aged 5 to 12 years, wherein 24.8% were in children up to 5 years. In many countries, 27% of cases occur in 0 to 4 years. Of this, 29.7 less than 2, 9.9 less than 1 year, and 2.9 less than 6 months. So even in infancy, we see typhoid cases. A case fatality rate is 1 to 4%. The WHO case definition, a suspected case of typhoid or paratyphoid is when there is fever for at least 3 out of 7 consecutive days in an endemic area, like what I showed, or following travel from an endemic area. Fever for at least 3 out of 7 days within the 28 days of being in contact with a household contact, the confirmed case of typhoid or paratyphoid fever. Confirmed cases, typhoid fever, lab confirmed by culture, molecular methods, or DNA from a normally sterile site. Paratyphoid fever, lab confirmation by culture, molecular method, or detection of DNA from a sterile site of Salmonella paratyphi. Relapse is when you confirm from from a normally sterile site within 1 month of completion of the appropriate course of antimicrobial treatment and resolution of symptoms. Chronic carriers. Carrier state is also known in children, though it is very less. Presumptive carrier is evidence of shedding of Salmonella species, positive stool culture or PCR of unknown duration. Definitive carrier is evidence of shedding of the species by positive stool culture or PCR at least 12 months after finishing the appropriate course of antibiotic treatment and resolution of symptoms following a lab confirmed acute episode, or 2 positive stool samples 12 months apart. Convalescent carrier is evidence of shedding of the organism 1 to 2 months after completion of the appropriate course of antimicrobial and resolution of the symptoms following a lab confirmed episode of acute disease. This is the Ncdc definition, which is simpler and easier to follow. Confirmed case, a patient with fever 38 degrees and above that has lasted for 3 days with lab confirmation by positive culture either from blood, bone marrow or bowel fluid of S. typhi. Probable case is a patient with fever 38 degrees centigrade and above that has lasted for 3 days with positive serology or antigen but without isolation. Acute non-complicated disease is when the patient has got prolonged fever and altered bowel function in children, mainly diarrhea, headache, malaise, anorexia, cough, and exanthems, rose spots on the chest, abdomen in the early phase of the disease. Complicated disease is one when the disease is severe with abdominal pain, occult blood in the stools, melena, perforation, peritonitis, myocarditis, pneumonitis, enteric encephalopathy. Etiology. It belongs to the genus Enterobacteriaceae, rod-shaped, gram-negative, facultative anaerobe, motile with peritrichous flagella which bears the H antigens and polysaccharide somatic O and the capsular virulence antigen. This virulence antigen is, however, not present in paratyphoid A and B, so the vaccine may not be effective against it. The onset and severity of the disease mainly depends on the virulence of the organism and the infective dose. Primarily affects the mononuclear phagocytic system, intestinal lymphoid tissue, and gallbladder. Protection is brought about by cell-mediated and humoral response. The pathogenesis, as you can see, the Salmonella typhi enter the enterocytes lining the terminal ileum and enter the M cell, then the Peyer's patches in the macrophages, they multiply, then go to the mesenteric lymph nodes. From there you have spread to the blood primary bacteremia. Till then the child may not have any symptoms. Then subsequently there is seeding of the reticuloendothelial system, liver, spleen, gallbladder and bone marrow. And finally there is a secondary bacteremia. And during this time the patient will have all the symptoms. And of course again it may get re-exposed via the bile. The incubation period is 7 to 14 days, ranges from 3 to 30. Some books give it even longer. And following the incubation period, the child can have mild illness with low-grade fever, dry cough, malaise, to very severe illness with very high fever, abdominal discomfort, headache, and complications. Below 5 years, they can have symptoms of diarrhea and toxicity, and complications are more common in infancy. Relative bradycardia is rare in children. Similarly, the stepladder type of fever and a fall by crisis can occur in children also, but it is uncommon, unlike in adults. These are some of the features like rose spots seen in 25% of cases. On the day 7 to 10, they disappear, appear in crops of 10 to 15 and disappear after 2 to 3 days. They are, however, not seen in dark-skinned individuals. From one of the studies, the common clinical features and the percentages are given here. High-grade fever 95%, coated tongue 76%, anorexia 70%, hepatomegaly 37%, splenomegaly 17%, and of course the complication like ileus and intestinal are less, 1% and 0.5%. The complications seen to occur very rarely in children include intestinal hemorrhage, perforation, toxic myocarditis, where you can have arrhythmias, cardiogenic shock, and sinoatrial block, endocarditis. Neurological complications, delirium, raised ICP, acute cerebellar ataxia, chorea, deafness, GBS, meningitis, and one of the speakers, he told aphasia he has seen, and renal complications like HUS, pyelonephritis, nephrotic syndrome, bone marrow necrosis, which can be fatal, DIVC, parotitis, orchitis, suppurative lymphoadenitis. This is a crowded slide. It shows the risk factors for the various complications. For CNS complications, the risk factors include endemicity, congenital heart disease, paranasal sinus infection, pulmonary infection, meningitis, trauma, osteomyelitis in the skull, cardiovascular, valvular abnormalities, congenital heart disease, rheumatic heart disease. Pulmonary, the child who has a past respiratory infection, sickle cell anemia, diabetes, HIV, and endemicity. Bone and joint, sickle cell, SLE, liver disease, those who are on steroids, lymphomas. Hepatobiliary, splenic trauma, hemoglobinopathy, HIV, and pyogenic infections. Urinary tract pathology, and soft tissue and hematological problems like hemophagocytosis. Mostly there is a diabetic mellitus. Differentials are very the common illnesses which we come across in a child with fever. All will come as a differential diagnosis. Acute gastroenteritis, bronchitis, bronchopneumonia, malaria, sepsis, tuberculosis in all forms, brucellosis, tularemia, leptospirosis, rickettsial, all tropical infections, viral infections like dengue, hepatitis, infectious mononucleosis. And of course, even now, COVID and the MISC, all that we also have to rule out co-infection when we are treating them. Investigations, CBC will be of some help because frequently in 20 to 30% of children, the total count can be low, but in younger children, leukocytosis can occur. And of course, it can occur when there is an abscess formation later as a complication. Eosinopenia has been described, thrombocytopenia. The gold standard for diagnosis is blood culture. Sensitivity is highest if done in the first week of illness. Overall sensitivity is about 50%, positive in 40 to 60% of patients. Yield affected by the rampant use of antibiotics on clinical suspicion prior to blood culture, late presentation of patients to the tertiary care, and inadequate blood samples. Bone marrow culture is more sensitive, but not feasible because of the technical issues and the severe pain which can result. It is important to ensure that the optimal volume of blood is sent, as the bacterial load in acute typhoid is low with an average of less than 1 colony forming unit per ml. The volumes of the blood needed for enteric culture: 40 ml broth in pediatric age group, 3 months to 2 years, 1 to 2 ml, 2 to 5 years, 2 to 3 ml, 5 to 15, 5 to 10 ml, over 15 years, 80 ml broth containing 8 to 10 ml. Other cultures like urine culture, stool culture can be done. Urine culture after 3 weeks, by 4th week it can be positive. Duodenal aspirate can be sent for culture. Stool culture by 3rd week, mainly it is used for detection of carriers. PCR is another test found to be more than 90% sensitive, but it's not a gold standard test. Picks up only antigen to 14, 15, and 18, cost is high. Nested PCR is more sensitive and uses H1D primers to amplify the specific genes of Salmonella typhi. Advantages are the higher case detection compared to blood culture, can be used as a diagnostic test at any stage and not affected by antibiotic use. The other investigations, this blood culture already we have seen. About bone marrow culture, it can be done if suppose the blood culture has not yielded and still we are suspecting, but the procedure is painful. Polymerase chain reaction, already I have told you. The next is the Vidal test, which is widely used despite its low utility. It is poorly sensitive, often leads to misinterpretation of results. Sensitivity is from 47 to 77%, specificity 50 to 92%, low predictive value 5.7, negative in 30% of culture positive cases. So even if culture is positive, it can be negative. And the titers are O above 1 in 80 and H above 1 in 160 are usually taken in many of the labs as suggestive of enteric fever. The challenges and comments include varying cost. False negatives are high in the endemic areas. False positive can occur in malaria, typhus, cirrhosis, salmonella infections. One should be very careful in interpreting to avoid antimicrobial overuse and antimicrobial resistance. Rapid diagnostic tests like Typhoid in various forms, variants like Typhi, Rapid, Typhoid-M, Latex, IgM, Dipstex, all are available. Sensitivity is 95%, specificity is 75%. Detect IgG and IgM to 50 kD outer membrane protein. The limitation is persistence of IgG for more than 2 years after an infection. So Typhoid-M makes use of the procedure by which the IgG is inactivated. So during the acute phase, IgM can be detected. Other tests include the typhoid, paratyphoid test, gas chromatography, and time of flight mass spectrometry, a portable system, immunomagnetic cell capture system, strip-based typhoid diagnostics, loop-mediated isothermal amplification, microwave accelerated metal enhanced fluorescence. All these are done in research labs, and some of them are not yet to be validated for general use, except the typhoid paratyphoid test, which is validated in some countries. The challenges in the diagnostic: the most frequently used Vidal test has its limitations. Blood culture followed by PCR to capture the small number of bacteria show variable sensitivities, but it is highly specific. Multiplex PCR and stool dipstick tests help in early diagnosis. However, they remain unacceptable for routine use in India. Antigen-based rapid diagnostic test kits like Tubex, Typhoid-M have limited use in clinical labs. Other assays like ELISA, immunoassay, immunoelectrophoresis, coagglutination have restricted use due to several technical issues. Hence, blood culture remains only the most important diagnostic tool. Challenges in the diagnostics: although a point of care test is urgently needed to differentiate enteric fever from other febrile illnesses, a clear and profit-intensive market for diagnostic is unavailable. Obtaining a non-invasive and accurate reference standard is challenging. The issue of incentivizing for its use rather than cheaper empiric treatment needs special attention. Before going into the specific drug treatment, I thought I would give an importance to the antibiotic resistance which we are seeing now. So that has to be stressed. That is one part of the management. In 1948, chloramphenicol was introduced for treatment of typhoid. Antimicrobial resistance seen within 2 years. And by 1972, India reported the first outbreak of chloramphenicol. 1990, it became resistant to all the first-line drugs. Some strains have acquired resistance to fluoroquinolones, and third-generation cephalosporins are being used in the treatment. The S-type H58 clade with H1 incompatibility type plasmids, they carry the multi-drug resistant genes and mutations causing fluoroquine resistance, fluoroquinolone resistance, and is responsible for much of the recent and current spread. This is said to have emerged in Indian subcontinent and spread to Southeast Asia, Sub-Saharan, Nigeria, and Congo. Salmonella typhi resistance to third-generation cephalosporin caused outbreaks of extremely drug-resistant typhoid in Pakistan. The antimicrobial resistance in typhoid and increased number of XDR cases will cause severe limitation of treatment options, and the only option left would be azithromycin. Some of the molecular studies, however, did not demonstrate extended spectrum beta-lactamases in S. typhi in India. So that is good news for India. Only sporadic reports of typhoid resistant to third generation. That is why I am going to only talk about the third generation cephalosporin. Classification of drug resistance. Non-resistance is typhoid fever caused by Salmonella paratyphi sensitive to first line and third generation cephalosporins with or without resistance to second line drugs. Multi-drug resistance typhoid fever is when it is resistant to the first line of drugs with or without resistance to second line drugs. Extensive drug resistance is resistant to all the recommended antibiotics. National treatment guidelines for antimicrobial use. according to the NCDC, for outpatient, once diagnosed, oral cefixime 20 milligram per kg per day for 14 days. That is very important. If you are using Erythromycin on an approved case, you can use it at a dose of 20 milligram per kg for 7 to 10 days. For inpatients, ceftriaxone 100 milligram per kg, shift to oral cefixime once the child is afebrile, which is what we are usually doing, and continue the antibiotic till 1 week post defervescence. Alternate therapy include chloramphenicol, trimethoprim, ofloxacin. Antibiotics, however, should be continued for 1 week in the dose mentioned after the fever defervescence. Abuse of erythromycin, this is what I want to stress, for other conditions should be stopped because the threat of extremely drug resistant typhoid is looming large on us as it is there in Pakistan. Prevention of antimicrobial resistance by rational use of antibiotic and antibiotic stewardship is essential to prevent multi-drug resistant and extremely drug resistant typhoid. Controlling the sale of over-the-counter antibiotics, educating the health professionals in the rational use of antibiotics and imminent danger of antibiotic resistance is the need of the hour. Antibiotic stewardship. In 2011, Government of India launched National Policy and Chennai Declaration in 2012, 5-year plan. National Center for Disease Control and IAP had formed prevention by improving the sanitation, prevention of antibiotic resistance and vaccination. Sanitation, India, the Government of India, Swachh Bharat Mission, and universal, affordable, sustainable access to water and hygiene is the key to prevention. Average rate of hand washing is around 15%. Net cost for not hand washing is around US 23 billion. And the net returns of behavioral change would be about 5.6. Teaching hand hygiene and hand washing in schools is very important. Food hygiene is important. Consumption of open street food avoided. Food taught handlers taught hand hygiene. Vaccination important. Vaccines used are the typhoid conjugate vaccine above 6 months up to 45. Polysaccharide vaccine above 2 years. Live attenuated typhoid 21A vaccine not available in India. The conjugated vaccine is recommended from 6 months onwards. Booster dose is not used now, and it can be co-administered along with measles vaccine. It shows that conjugated vaccine has more sustained level of antibodies compared to V1 polysaccharide, and it also suggests the protection and persists beyond 5 years. Typhoid BEV is the new entrant. V1 antigen is from Citrobacter frendi, which is a commensal, and dose is same 0.5. It is conjugated with CRM protein. It is licensed for use in India for children over 6 months up to 5 years, and to be given at a dose of 0.5 ml IM. This is the polysaccharide vaccine, which is given about 2 years IM or IV, IM or subcutaneous, and it needs to be repeated every 3 years. It is mainly used for catch-up and outbreak use. Oral typhoid 21A, 3 capsule, alternate days every 3 years. Who recommends the programmatic use of vaccines along with control measures like health education, water sanitation, and hygiene improvement. Training of the health professional and diagnosis and case management. Enteric fever continues to be a major public health problem in India. Emergence of extremely drug-resistant typhoid and spread may have devastating effect in the health and economics. Disease burden can be reduced by multi-pronged approach of government, healthcare professional, and public awareness. Though blood culture is the gold standard in the diagnosis of typhoid, positive blood culture rates are low. Improving sanitation, hygiene, and vaccination with typhoid conjugate vaccine may reduce the disease burden. Thank you for the opportunity.
Thank you, sir, for the detailed talk on enteric fever. I request the participants to post your questions in the chat box.
Thank you, sir. Thank you, Sabrita. I think we have one question from Professor Nedunjazhan, sir. He asks, do we have an antibiogram for enteric culture in our hospital?
Actually, we are having the culture reports, and the infection committee has come up with the antibiogram for most of our infections, ICU infections, NICU. So we have an antibiogram for enteric culture.
Right. So all culture reports are generally given with the sensitivity pattern as well as per the antibiogram. Sir, I just have one question, sir, as a student. Sir, very frequently we see people jumping to another antibiotic after starting cefixime for a few days, like 2 or 3 days, a child still remains febrile for a presumed diagnosis of enteric fever, they quickly shift to an antibiotic like azithromycin or something. So how long should we wait for an uncomplicated enteric fever for defervescence before we conclude that there is something else going on and we need to change antibiotics?
After starting antibiotics, minimum of 5 to 7 days we have to wait. Only after that we can decide that probably it's not responding. And we have to be very careful in using azithromycin also, because that is the last antibiotic we have at present for enteric fever. And we should not use it for other infections like upper respiratory, throat infections and other things,
Right,
where other antibiotics are available.
All right, sir. Thank you, sir. One more question which I would like to ask is, in a child presenting with a 4-day or a 5-day fever without any localizing features, are there any clinical pointers to tell that it could probably be enteric fever?
After 4 days, see some of the features which I described, if it is there, like coated tongue, abdominal distension, diarrhea symptoms, and those things may point out to a probable diagnosis of enteric. Because enteric fever, it should be in our mind for all cases of fever. We have to be alert, because beyond 3 days only we will be able to do any investigation to find out what is the cause. And many of the viral infections by 3 to 4 days may subside. So if the symptoms persist beyond that, and we have features, and if you have a splenomegaly which develops, and hepatomegaly and other features, then of course the rose spots which I described are very rarely seen, and if it is seen, it is pointed towards that enteric fever. And one of the comments made by one of the presenters was hepatic enzyme elevation, if they are there and along with all other features, they also help in the diagnosis of enteric fever. Transaminases, they say that it's more reliable to depend on that.
Sir, and one more thing which is generally said, that eosinopenia is a fairly common finding in children with enteric fever. Is that true, sir?
Yes, it is common, but it also occurs in other viral conditions also. That's what. That's why it's not a major important factor. We cannot, but we can. All these factors will add to the diagnosis, like a coated tongue, the rose red spots, eosinopenia, and then low count, thrombocytopenia also sometimes. But thrombocytopenia occurs in so many other conditions. But if it is there, then we can start investigation. And one important thing is, even if the child has taken antibiotics outside, we should do a blood culture and then start our antibiotics once they come to our hospital, because that is very important, so that we can make out what is the organism and the sensitivity pattern.
Yes, sir. Thank you, sir. So one last question, sir. What is your comment about the Typhoid test which is used? Because you had told about the fallacies of using serology for diagnosis.
Yeah, that's what most of the articles, they say that it's not of much use, but it is an added point, just like a clinical feature, like an abdominal examination, you have some findings of abdominal distance, like that. It will add to your clue for diagnosis. It's not the only test.
So because
only
it has
test is blood culture. It has got a good sensitivity.
Rapid turnover time, probably it may be useful in decision making, because culture takes a while and serology also.
Yeah, it makes out IgM initially, and because the IgG is deactivated, and so early phase, first 1 week, it can be used, but it's not a confirmable, because probable case of typhoid we can call it, not a confirmed case.
Right, sir. Thank you, sir. I think there are no more questions. We'll move to the next talk. I hand over
Thank
to
you, Dr. Sivan.
Thank you, sir.
Thank you, sir. The next talk is on diagnosis and management of UTI, what is right and what is not, by Dr. Suganya Govindan, consultant pediatric nephrologist at Mehta Hospital. Over to you, madam.
Thank you. So I'd like to thank at the outset the pediatrics department at Mehta Children's Hospital, and also Shivan for wonderfully taking up this exercise. Just a second. Yeah. So the topic that I would be speaking on today is the pediatric UTI, its diagnosis and management. This topic is quite interesting in the sense that there are multiple well-designed studies that have come out in the recent years after the ISPN 2011 guidelines that we all know about. And many of these studies are turning out to be game changers and also are going to influence our decisions in both diagnosis and how we look at children with febrile UTI at follow-up. So in the next few minutes or so, I'd like to discuss briefly about the epidemiology and the etiology of UTI, how to correctly make a correct diagnosis of UTI, how to treat a child, both the initial episode, and then how to follow up a child with febrile UTI. So if you see, UTI is a very common childhood infection, and especially in children who present with fever episodes, almost when 0 to 19 years, almost 7% of them turn out to have UTI. So it is very common. However, there are specific age groups which have a higher baseline prevalence of UTI, especially uncircumcised male infants of all the age groups have the highest prevalence of UTI. And the next in order is the females who are less than 1 year of age. And females again tend to have an increase in prevalence of UTI around adolescence, especially due to the increase in sexual activity and the changing anatomy that they have. Of importance to us is also this incidence of recurrent UTI. Almost up to 30% of children who have had a febrile UTI are likely to have a recurrence of UTI sometime in their childhood period. And the major causes, or rather, I should correct myself and say associations with UTI, is vesico-ureteric reflux and bladder bowel dysfunction. UTI is majorly caused by organisms that are present in our fecal flora, and almost 90% of these infections are caused by this particular variety of E. coli, the uropathogenic E. coli. I'll come to you in a minute why they are so important. The other organisms also belong to the Enterobacteriaceae group, the larger group, and include Klebsiella, Enterococcus, Enterobacter, Proteus, and Pseudomonas. E. coli are the predominant organisms causing E. coli, so much so that some guidelines look at non-ESBL E. coli as having an atypical UTI and recommend evaluation further for these children. Also to note is the emerging antimicrobial resistance, especially in this group of Enterobacteriaceae bacteria, because of the emergence of these extended spectrum beta-lactamases and also multi-drug resistant E. coli that we time and again see. In our own center, the last 2 years, we have had almost an incidence of around 30% of our urine cultures in children have turned out to be ESBL. And what makes these bacteria more likely to cause a UTI is something like this. So all of us have a constant urinary flow. So that itself sort of prevents having an episode of UTI. And that's why most of us do not develop an UTI. But then E. coli, especially uropathogenic E. coli, specifically, they have this P. fimbriae or the pili, which sort of helps them to adhere to the uroepithelial surface. And this adherence is helped by the epithelial receptors of CD14 and the toll-like receptors, which together, when this activates a cytokine pathway, which is heralded by this NF-kB. And this is a very broad spectrum inducer of chemokines and cytokine response. So we have all these cytokines and chemokines that are being released after an episode of, after the attack of E. coli. So you have interleukin-6, which sort of produces fever and other symptoms of UTI. And you have interleukin-8, which causes the increase in WBC recruitment, and hence we see pyuria in our urine. And also the inflammation and the rhinomegaly and the pyelonephritis is majorly caused by TNF-alpha. Not only this, but the important thing here is based on the reaction on the virulence of the bacteria and also on the response of our own body to it, some of the children might actually go on to develop renal scarring, because this pathway also sort of sometimes triggers the scar formation by activating the mesenchyme and the fibrotic pathway. So here, the balance of who gets a UTI and how severe a UTI is going to be and who develops lifelong complications of UTI, like in scarring, is going to be determined by the balance of germ characteristics and host factors. The important germ characteristics, as I said, are pili of Fimbriae, which help in adherence of bacteria to the uroepithelial surface, plasmids in bacteria, which govern bacterial resistance, and also the individual virulence of a particular organism. Children with problems in urinary flow, having increased urinary stasis, are more likely to develop UTI. Also, bowel and bladder dysfunction, which is an important cause of functionally abnormal urinary tract. And also the host-mediated inflammatory response sort of dictates who gets how severe an UTI. We also use several terms while classifying UTI. Of the most important classification or the terms that we use are the upper UTI and the lower UTI. So the upper UTI is something that involves only the kidneys and the ureters, and the lower UTI is something which involves the bladder and the urethra. So the upper ureter, the reason for dividing this is also, one is they present differently, and they also have different inferences or different meaning to us when in terms of treatment and follow-up. So the upper UTI are usually children present with high-grade fever. They have more systemic symptoms like fever, vomiting, and poor oral intake. Some of these children can have renal angle tenderness, which is synonymous with having an acute pyelonephritis. Lower UTI, predominantly, there is either low-grade fever, but there's definite association of lower urinary tract symptoms like urgency, frequency, and dysuria. The other terms that we use are a simple or uncomplicated UTI and a complicated UTI. I've put together both the ISPN terms and the NICE guidelines terms for this classification, which includes any child with who is more than 2 months of age with a normal urinary tract and a normal renal function and a competent immune system is thought to have a simple UTI. The same way, complicated UTI is suspected in children who are less than 2 months old, have an abnormal urinary tract, have presence of renal angle tenderness, abnormal renal function, or generally systemically unwell. Either they are toxic, they are unable to tolerate oral fluids and unable to tolerate oral medications. They're either immunocompromised or have features of septicemia like hemodynamic instability. Coming to the clinical presentation, so when should you suspect a child to have UTI? The clinical presentation also sort of depends on the age, with children, infants less than 2 months having the most non-specific of complaints, and one should always think of them having a UTI if they present with poor feeding, lethargy, jaundice, and septicemia. This group is also particularly more likely to develop septicemia, bacteremia, and develop a serious bacterial infection after an episode of UTI. Children with 2 months to 2 years are probably the most confusing of this group, and most of them present with fever without a focus. And in this particular group, if we take, almost 5% of them are supposed to have a UTI. And children with more than 2 years of age usually have symptoms referred to the urinary tract. Might not always be true, but most of them are able to have symptoms most likely present with a symptom which is referred to the urinary tract. So when do we test for UTI? Taking guidance from the same age-based classification, when you have an infant who's less than 2 months and presenting with non-specific symptoms, almost always do urine testing to rule out a UTI. And in children between 2 months to 2 years of age, it's worthwhile if you could do a urinary testing, not at the first day of fever, but rather wait and if they have persistent high-grade fever of more than 3 days duration. And in children with more than 2 years of age, almost always take a urine sample when they have symptoms of the urinary tract. So how do we confirm the UTI once you suspect it? Urine culture till date remains the gold standard technique. There are, however, plenty of supportive or screening tests that one uses in the clinic or in the emergency room to confirm or to support your diagnosis of UTI. These include the urine microscopy, the nitrite test, the leukocyte esterase, and bacteriuria. Urine culture is, although it's the gold standard, it's still the most cumbersome of tests that I have mentioned before. The collection method can be any of these two. The bag and pad sampling is probably the least preferred method. This is okay for dipstick testing, but however, for culture, it can yield higher contamination rates of almost, some studies mention almost up to 80%. The NICE guidelines sort of mention a clean cat specimen, and only when this is not possible, they advise you to go for catheterization and SPA. However, the AAP guidelines clearly states it's for infants less than 24 months. So they clearly state it's either by catheterization or a suprapubic aspiration. And all of these methods need perineal cleaning with soap and water, and it's preferable not to use medicated soap. The colony count and required to confirm a UTI also depends on the method of collection. The suprapubic aspiration, sort of any number of any growth, is going to increase the probability of UTI. Catheterization, the ISPN guidelines, the earlier guidelines had this cutoff of 5 into 10 per 4 and a clean catch of more than 10 per 5. Lower counts, however, should be taken into account if the child is particularly symptomatic. But however, this ISPN guidelines is being updated this year. It's still not available yet, but I have permission to share a few details from the ISPN convener group. So these should be taken with these are still provisional. They are still not vetted by the entire committee. The recent ISPN update sort of have sort of changed a bit about the colony count. The catheterization sample now, it's not 5 into 10 per 4, but rather 10 per 4 ml. And symptomatic infants have sort of now given a cutoff of more than 10 per 4 colony forming units. They also tell you, suggest that we should not treat asymptomatic bacteriuria, and there's no need for doing a repeat culture in a child who's already had a positive urine culture and is on treatment unless there is no clinical response to treatment. The other screening tests are usually used to guide whether to do a culture or not. And if you are in the ER, if you can sort of decide to do a urine culture only in children who have these screening tests which turn out to be positive. So the most common screening test that we use, almost all of us would use, is a urine microscopy to look for WBCs and bacteria. Significant pyuria means more than 10 WBCs in unspun urine, or more than 5 WBCs on a centrifuge specimen of urine, or having a leukocyte esterase which is positive on a dipstick. So all these tests, if you see, they're all quite sensitive. The nitrite is more specific, but in individual, when taken in isolation, these tests do not perform that well. But in combination, either a leukocyte esterase and nitrite combination sort of gives you a very good sensitivity, almost 93%. And when combined with WBC or the microscopy, sort of the sensitivity reaches almost 99.8%, meaning that these tests have a good negative predictive value. They are always better at excluding UTI. So a good practice in the ER or in your clinic would be quickly do a dipstick, and if it is positive, to go on to retrieve a urine culture in such child. These tests are not at all expensive, with each strip costing less than 10 rupees, and it looks something like this. This comes with an entire, the protein glucose dipstick, also the leukocyte and the nitrite dipstick. So moving on to treatment. So what do you do once you confirm an episode of UTI? The recent guidelines, we are sort of moving towards using more and more oral antibiotics and shorter duration of therapy. The ISPN 2011 guidelines suggested for simple UTI a duration of 7 to 10 days, which is being now changed to a total of 3 to 5 days. For complicated UTI, the duration sort of remains the same. However, clinical practice point suggestions are being given, which suggest that although this is the total duration of antibiotics, and in a patient with complicated UTI, they suggest giving only the initial 2 to 3 days as IV antibiotics, especially for infants who are 1 to 3 months of age with acute pyelonephritis, and then further on going on to complete the course of 10 to 14 days with an oral antibiotic. All other children can be started off with an oral antibiotic itself. And also, this 10 to 14 days duration sort of is again suggested to be reduced in children with more than 6 months of age to 7 to 10 days if they show adequate improvement. So oral antibiotics almost always in all children with simple UTI and more than 3 months of age, and only in children who have who are neonates and who have bacteremia or sepsis at the initiation of therapy should go on to receive IV antibiotics. The preferred drugs for parenteral therapy remain ceftriaxone, which also in our center probably is the most widely used antibiotic in a febrile episode. The other antibiotics are cefotaxime, amikacin, gentamicin, and comoxiclav. Of particular importance is what do you do when you get an ESBL growth? As I discussed, we did see a lot of ESBL growth, and these bacteria are not only now confined to hospital isolates, but they're also now emerging in community-acquired urinary tract infections. So the interesting thing that many studies have noted, and also our own data also seems to suggest, is that many of these children, despite having an ESBL growth in urine, sort of have a good response to ceftriaxone, even if the culture report does not show sensitivity to ceftriaxone. So ceftriaxone seems to be a good antibiotic to start, even if your center has an increased incidence of ESBL in the UTI. The other oral antibiotics preferred ones are cefixime, coamoxiclav, and fluoroquinolones. Cefalexin also could be used in as a good oral antibiotic. So simultaneously, when you're treating a child for UTI, you should simultaneously assess them for associated risk factors. One, you look at the clinical risk factors, if any, that you could pick up on a history and clinical examination, which will guide the need for further imaging in these children. And with every imaging, our goals are to assess the risk of future or recurrent UTI.
5 more minutes, madam.
And also the risk of upper tract damage or an underlying kidney and urinary tract abnormality. So the initial evaluation clinically should depend on these factors. One could look at look for the presence of a distended bladder or an enlarged kidneys, having a tight phimosis of vulval synechia. A palpable fecal mass could denote an underlying bladder bowel dysfunction, a neurological deficit in the lower limbs or a patulous anus, and a urinary incontinence. Any previous surgery or anorectal malformation or a spinal anomaly should indicate an underlying renal problem. The NICE guideline sort of divides these children into a term nicely called the atypical UTI. If the child is seriously ill, meaning hemodynamically unstable or not responding to antibiotics within 48 hours, having a poor urinary flow in the form of hesitancy, intermittent stream, or having a poor urinary stream, having an abdominal or bladder mass, having renal dysfunction, having septicemia, and infection with non-E. coli organisms are considered to be atypical. Also, children with recurrent UTI definitely need further imaging. The ISPN guidelines define recurrent UTI as any second episode of UTI. However, the NICE guidelines probably gives a better definition, which is more than 2 episodes of acute pyelonephritis or an upper UTI, more than 3 episodes of a lower UTI, or a combination of a single upper UTI and a more than 1 lower UTI. So any children with recurrent UTI or any of these atypical symptoms on your clinical history and the course of treatment should indicate to you that this child is at risk of having a recurrent UTI or a Acute underneath, and you should push them for further evaluation. The other important factor that one should try and rule out at every episode, at every child of UTI, is the presence of bowel and bladder dysfunction. So this is a very subjective assessment, but in the recent years, many societies have put together this questionnaire, which sort of performs very well in children with UTI. Is this bowel and bladder dysfunction scoring, which has a series of questions to be taken by the parents and the children with help of the parent, and it sort of gives you a scoring based on the frequency of these symptoms that you have. The major symptoms are wetting your underpants, having to have constipation and straining, or having no bowel movements at all, having dysuria or lower urinary tract symptoms. And the threshold for diagnosis is slightly lower in females because they tend to have more of bowel and bladder dysfunction. And this scoring sort of performs very well in identifying children with bowel and bladder dysfunction. This in combination with a urine and a stool diary using a Bristol stool chart, and also a urine volume and a stool type and frequency diary sort of helps you assess which children are at risk or which children could have an underlying bowel and bladder dysfunction. The initial imaging is again differs across guidelines. I'll just mention the most common ones. The NICE guidelines suggest almost always in less than 6 months of age suggest doing an ultrasound, and in more than 6 months when you have any atypical features. The American Academy of Pediatrics, however, suggests imaging in all children, the ultrasound imaging, and our own ISPN 2011 guidelines also suggests ultrasound in all children with an episode of UTI. The further imaging sort of differs with various guidelines. And usually if you have an ultrasound, abnormal ultrasound, or if you have risk factors, you go on to perform a late DMSA scan and also a VCOG. None of these guidelines recommend an early DMSA, which is getting a DMSA during an episode of UTI or within 2 weeks of having an acute episode of UTI. This is our ISPN guidelines, which was there in 2011. It sort of recommends children who are less than 1 year with an episode of febrile UTI should undergo all 3 imaging, the ultrasound, MCU, and the DMSA. And children between the age of 1 to 5 years should have an ultrasound and a DMSA scan. This DMSA is a late DMSA scan, which is recommended up to 8 to 12 weeks after an episode of UTI. And if any of these is abnormal, to go ahead and do an MCU. And in children who are more than 5 years of age, to do an ultrasound, and only if the ultrasound is abnormal do they require further imaging. With more and more data available, the ISPN guidelines are also sort of moving towards imaging in only selected patients and not imaging in all patients. And what constitutes an abnormal ultrasound? So we all knew that up till 5 years of age, the decision to go for further imaging depends on an abnormal ultrasound on even after 5 years. So what constitutes an abnormal ultrasound? Having asymmetry of the kidneys, having hydronephrosis or urinary tract dilatation, ureteric dilatation, any bladder abnormality or an increased post-void residue, and altered echogenicities. Rhinomegaly and cystitis, especially in a child who's febrile, should not be taken as an abnormal ultrasound and should not trigger further functional or MCU imaging. And when do you do a repeat renal ultrasound? Repeat renal ultrasound is recommended when you do not have a good response to the initial antibiotic therapy, and also when it's recommended only after a period of 2 to 4 weeks when you're landing up in problems with initial treatment. The other commonly discussed approach is the top-down versus the bottoms-up approach. I'll just mention a few points about this. In the top-down approach, our primary interest is the upper tract damage. So it sort of starts with the DMSA, and only who have identified upper tract damage like renal scarring by DMSA go on to receive further imaging. While in the bottoms-up approach, the onus is on finding a VUR, and it's only VUR is thought to produce more renal scarring. It's based on that logic. And then if the VUR is present, they go on to receive a DMSA scan. There are certain advantages with doing a VCOG. First, it's reproducible and easily interpretable. And this is probably the only imaging technique that can exactly identify all the lower urinary tract anomalies. But however, it involves radiation, it involves catheterization, and children can also have an infection post an MCU, and it does not give any information on the upper tract. However, the top-down approach definitely identifies renal damage and avoids catheterization, but it gives you no information on the lower urinary tract, and it also involves radiation. Coming to antibiotic prophylaxis. So which children should receive antibiotic prophylaxis? The preferred antibiotics are these, which is cotrimoxyl and nitrofurantoin in any infant after 6 months of life, and cefalexin or cefdroxil in infants less than 6 months of life. And who to give? The ISPN guideline says UTI below 1 year of age while awaiting imaging studies, which are the MCU and the DMSA, any child with VUR, and a child with frequent febrile UTI, which is defined as 3 or more episodes in a year. When dealing with children with VUR, the lower grades of VUR, like grade 1 and grade 2, it's recommended that they receive prophylaxis till 1 year of age, and then it can be stopped. But however, consider restarting if these children have a breakthrough UTI or after stopping a prophylaxis. The grade 3 to 5 prophylaxis is recommended up to 5 years of age, and surgery is also recommended in case they do not respond to breakthrough UTIs. And beyond 5 years, prophylaxis should be continued till there is bowel and bladder dysfunction. Currently, the AAP and the NICE guidelines, so what I discussed now is the ISPN 2011. The AAP and NICE guidelines, however, do not recommend routine neuroprophylaxis after the first episode of febrile UTI. So what happens in an abnormal urinary tract? So we are moving towards no prophylaxis in children with normal urinary tract, and also prophylaxis in children with abnormal urinary tract is being called into question because of recent evidence where it's thought that VUR is rather a bystander rather than the cause of recurrent UTI, and prophylaxis is only marginally better even in children with high-grade VUR. And scarring, recent studies have shown, is not prevented at all by long-term prophylaxis. And renal scarring is thought to be related to renal dysplasia rather than recurrent recurrent UTI and high-grade VUR. Also, what we have seen in longitudinal studies is that the risk of ESRD in children with vesico-ureteric reflux has not changed much with prophylaxis, which all these children have received in the last decade. And VUR as such is now recognized as having a low risk of progression to end-stage kidney disease, and also the association of increased antimicrobial resistance with children receiving antimicrobial prophylaxis. Most of these evidence is coming from this trial and a few more trials similarly done in the last decade. This is one of the largest prospective RCT in children with VUR, with having 607 children randomized to receive either trimethoprim sulfomethoxazole prophylaxis or placebo after an episode of first or second episode of symptomatic UTI. If you see, majority of these children were smaller infants, less than 1 year of age, and were females, and 91% of them had been randomized only after the first episode of UTI. And almost 56% of these children had bowel and bladder dysfunction. All of them had grade 1 to 4 VUR. So the outcomes that they tested were the recurrent incidence of recurrent UTI, renal scarring, prophylaxis failure, and antimicrobial resistance. Of importance are these outcomes. The prophylaxis definitely induced the risk of recurrent UTI by almost 50%. So prophylaxis definitely helped preventing a further episode of UTI. But it did not prevent new renal scarring. The renal scarring rates were 8.2 versus 8.4 in the group of prophylaxis and placebo. And renal scarring was likely, however, more likely in older children who had a second UTI before enrollment and higher grades of VUR. They also found that children who received antimicrobial prophylaxis had their first recurrence was with a more resistant E. coli. And this resistance was almost 63% versus only 19% in children who did not receive prophylaxis. However, this finding should be taken with a pinch of salt, because this study, if you see, did not involve much older children, and children with more than 2 episodes of UTI were excluded. And also renal scarring was not their primary endpoint. So it's probably too early to jump and say that prophylaxis does not prevent renal scarring. However, this study sort of tells us that the focus should shift from no prophylaxis, which is recommended by the AAP and the NICE guidelines, to sort of a selective prophylaxis in children with higher grades of VUR and more recurrent UTI. So the ISPN 2021, again, this is a provisional recommendation, now suggests that no prophylaxis after the first episode of febrile UTI in children with normal urinary tract. However, you should consider giving prophylaxis in children with higher grade VUR, and also in children with lower grade VUR and having a recurrent UTI. Also, they suggest discontinuation of prophylaxis in children who are more than 2 years if they are toilet trained, have no evidence of bowel and bladder dysfunction, and have had no UTI in the last 1 year. There are a few more strategies which are non-pharmacological to prevent recurrence in children with a tendency to have recurrent UTI. These are being incorporated into guidelines. Cranberry extracts, which we tend to see in supermarkets, are thought to actually decrease the incidence of recurrent UTI. However, they are not better than prophylaxis, but in some children can almost work as beneficial as prophylaxis. So infants with recurrent UTI but with a normal urinary tract, our recent guidelines sort of recommend using cranberry extracts. Circumcision should almost always be offered to all male children with the risk of recurrent UTI. Treatment of BBD, I cannot overemphasize this. Behavioral modification, usually BBD involves more of non-pharmacological therapy than pharmacological. So behavioral modification in the form of urotherapy, which is a broader term used for education, adequate fluid intake, reinforcing timed voiding, and increased or regular toilet time, and having a balanced diet. Children who fail to respond to this might be offered PEG-containing laxatives, which are the most beneficial in them. And these laxatives should be continued on a longer term. Short courses do not work. And drugs like anticholinergics and alpha blockers can be provided to children if, despite all these two, they end up having recurrent UTI or having a significant risk of having an upper tract damage. So to summarize, pediatric UTI is very, very common. Accurate identification and proper testing is essential before initiating therapy. And children with normal urinary tract and no atypical features tend to do very well. Bowel bladder dysfunction, higher grades of VUR, and recurrent UTI definitely need treatment. We are moving towards selective imaging and selective antibiotic prophylaxis in children with UTI. And almost at every clinic visit and every episode of UTI, our intention is to assess the risk of upper tract damage to prevent renal scarring and future risk of end-stage kidney disease. And non-pharmacological methods should always be offered to all children for preventing recurrent UTI. Thank you.
Thank you, madam, for the elaborate talk on the recent recommendations in the management of UTI. Moving on to the Q&A session.
Thanks. Thank you, Sukanya ma'am, and thanks, Sabita. Ma'am, there are a host of questions given the popularity of the topic. So I'd like to proceed with them. We have a set of questions from Nedunjadian sir. So he first asks whether we have an E. coli without P. fimbriae as well.
Yeah.
Would you like to take that now? Yeah.
Yes, so there are definitely E. coli without P. fimbriae, and only this group of uropathogenic E. coli. So some strains of them have P. fimbriae, and it is these strains that are more likely associated with atypical UTI. Almost all E. coli can cause UTI, but then the strains with the P. fimbriae have more adherence properties, and they tend to have cause a severe variety of UTI or have persistent UTI or tend to develop UTI in children with abnormal urinary tract, if that's what sir wanted to ask. So those UTI with E. coli having P. fimbriae are slightly different from the UTI that we see with non-fimbriae UTI.
Right. Thank you. Is there a difference in causative organisms for upper and lower UTI? Does this presence of P. fimbriae influence which part of the urinary tract they affect?
No, not really. So what dictates a child who has an upper UTI or a lower UTI is not the type of organism. It's sort of the type of urinary tract, the virulence of the organism, and as I said, the presence of functional or an anatomically different this thing. And the difference in how the host responds to so the child might have a completely normal urinary tract, but can have a varying inflammatory response to each and every episode of UTI. So that would dictate who gets an upper UTI and a lower UTI rather than the organism itself.
How common is an infant presenting with jaundice in our setting? You had mentioned about smaller children having fever with an unknown focus who then turn out to be having UTI. So comments about that.
Although jaundice, especially direct hyperbilirubinemia, is not per se would be a very common this thing, but definitely in children with who are less than 2 months of age or in the neonatal period. In fact, it's thought to be UTI is routinely done in all children who come with a persistence of physiological jaundice, when you have a prolonged physiological jaundice. So definitely it should be ruled out, although it's still not the most common. And we do have, because we are a good renal center, we do get children. These, and routinely doing LFT is also one of our practice. We do in most febrile children, but we do pick up time to time children having some mild degrees of hyperbilirubinemia. Right. But definitely in infants, in less than 1 month of age, it should be tested.
Right. Sir has also asked about the role of alkalinizing agents routinely in children with UTI.
This is more of a symptomatic treatment rather than, it does not alter the course of UTI. It does not lessen the duration of UTI. Rather, it's a symptomatic treatment. So when children, especially with those with lower urinary tract symptoms, so alkalizing agents sort of alter the pH, and in an inflamed bladder, they sort of give you that pain relief effect also. Other than that, alkalizing agents are routinely not recommended in a child with UTI, just for altering the course of UTI.
All right. Is bowel bladder dysfunction scoring being done in our setting?
Yes. So I would actually be happy if all of us would do it. We do sort of ask our trainees, and we have a questionnaire along with the Bristol stool chart that in recent years we have asked our trainees, our own pediatric nephrology trainees, to fill in when we go for a consult for a pediatric UTI. But however, this should be very common practice, and the questionnaires are very simple. They have very few questions to answer and sort of give you a objective load of the BBD symptoms that a child has. So it should be incorporated. It is not probably completely incorporated into our system yet, but it should be.
Thanks, ma'am. Is it preferable to give uroprophylaxis as a single dose per day at bedtime?
Yes, yes. So uroprophylaxis is preferred to be given at bedtime as a single dose. The reason being the urinary stasis is longer during the bedtime. So when the child sleeps, they tend to store urine for a longer time. The frequency of voiding decreases. So it gives a better protection if you give it at night. So it's preferred to give at night. Yeah.
Okay. Another question from sir is about circumcision. So is it to be done and how early to do it to prevent UTI?
So if you have, so circumcision should be offered to all male children who have phimosis and who have come to you with an episode of UTI. It should be offered. There might be parental hesitation to undergo a circumcision after the first episode of UTI. So what we currently do is sort of suggest to them that it's time that they get a UTI circumcision done. We can try non-surgical methods of applying a steroid cream and such, and would definitely recommend circumcision, however, in children in whom steroid creams have not helped, and in children who have recurrent UTI. So definitely, and especially if they have an abnormal urinary tract, at every clinical visit, we do reinforce that they get a circumcision done.
Right. We have a few questions about the much discussed topic of how to go about testing after an UTI. So, ma'am, in your practice, you had outlined all the guidelines and recommendations. In your practice, how do you go about testing a child for anomalies after the first UTI?
Yes, so in what we do currently in practice, regardless of what the guideline says, is look for atypical features almost always in every child, starting from the antenatal period. Even sometimes a sibling history of having a VUR and a recurrent UTI in a sibling also should raise alarm bells when a subsequent sibling comes to you with a UTI. So it's as far as the antenatal period and the sibling history that we go. So identify any soft sign or any abnormal or atypical points. And if it's there, definitely I would recommend an ultrasound after the first episode of febrile UTI, even if the child, when you see, is already defervescent and I mean already is afebrile, is nice, is not toxic at all. So in our setting, we should almost always do an ultrasound, because you might not get to see the child after treatment of that episode, because follow-up is not really that great in our setting, in our Indian setting. So an ultrasound is definitely done after an episode of UTI. How we proceed with the DMSA and an MCU is, again, DMSA, if you are doing it, always do a late DMSA. There is no role for early DMSA unless you are with a septic child and you're not sure whether it's pyelonephritis or not. Definitely do not go for an early DMSA. Go for a late DMSA. And in VCOG upfront in a child with febrile UTI coming at the first episode is done if you have an abnormal ultrasound, and especially if you have a bilateral abnormality or a bladder or a significant bladder component having a lot of bowel and bladder symptoms, dysfunction symptoms, and MCUG should be done. We still stick to guidelines when it comes to less than 1 year of age, because the load of VUR, of the chance of picking up a VUR is quite high in them. With older children, I tend to do a DMSA first, and only if the DMSA is abnormal, tend to do an MCU, unless my ultrasound upfront is abnormal or wanting to do an MCU first. So definitely DMSA in a child after an episode of febrile UTI, and especially if there is an atypical symptom. If there is an atypical symptom, almost always do an DMSA. And if there is upper tract damage, go for an MCU to detect an underlying VUR. So that is my current practice.
Right. Dr. Hamid has asked if in an infant less than 3 months awaiting an ultrasound, should we give him prophylactic antibiotics?
A prophylactic antibiotic, I think for treatment, yeah.
Yes.
Yeah. So awaiting an ultrasound, so ultrasound is not necessary to confirm a diagnosis of UTI, if that's what you're asking. So I would sort of, if I suspect UTI in a child, I would start the antibiotic immediately after taking the urine sample for culture and microscopy. And I would prefer to start the child on antibiotics, especially if the child is less than 3 months. These infections tend to be severe in them. So I wouldn't withhold an antibiotic pending an ultrasound. Rather give the antibiotic after taking a urine sample. And then the ultrasound might or might not show an abnormality. if you have a new UTI.
So you meant therapeutic antibiotics, sorry.
Yeah, therapeutic.
So ma'am, one more question. How do you define uncomplicated or simple versus a complicated UTI and a febrile versus afebrile UTI? Are they the same or are they different?
So there are two things actually. So a febrile UTI is of course associated with fever. There are also this term called symptomatic UTI, which includes febrile UTI, but it's not only febrile UTI. So you have lower urinary tract symptoms like urgency, frequency, dysuria, sometimes even malodorous urine and all that. They all come in together the term of symptomatic UTI. So in terms of recurrences, also we tend to use these symptomatic recurrences and febrile UTI recurrences. So those are two different terms. Complicated and uncomplicated UTI is sort of a very clinical differentiation, a clinical classification to differentiate who receives how long an antibiotic and whether they receive an oral antibiotic or an IV antibiotic. So infants who are less than 2 months or 3 months of age and who have bacteremia and sepsis and who have not responded to initial treatment, who are unable to take orally, all come under complicated UTI. So almost always initiate antibiotic therapy, if preferably an IV antibiotic for the initial few days, and then sort of move on to oral if they've responded well. All other children come into this category of simple UTI. They all do well. They all do very well with oral antibiotics, and they most likely improve very well.
Thank you, ma'am. Thanks for the exhaustive Q&A session. In addition to the amazing lecture, I think you answered most or probably all of the questions one could think of in UTI. Thank you, ma'am. Thank you. Over to Jyotsna for the next session.
Thank you, sir. The next topic is on Nipah virus by Dr. L.K. Premkumar, sir, Consultant Pediatrician, at Mehta Hospital. Over to you, sir.
Yeah, thank you. Just a minute. Yeah, is it okay?
Yes, sir.
Am I audible and visible?
Yes, sir. Audible and visible. Perfect.
Yeah, thank you. Good evening, one and all. First of all, I would like to thank my respected teachers, Dr. Gauri Shankar sir, Dr. Thangavelu sir, and Dr. Namle sir, and Dr. Nidhilan sir for giving me an opportunity to speak in this forum. And my special thanks to Dr. Shivan also for giving me an opportunity. Now, so far we have been talking about the routine cases which we have been seeing almost in daily practices, all general pediatricians. But the topic what I'm going to discuss about is a new virus. Still, most of us, we are not still completely recovered from a coronavirus still, but again, there's one more virus which we are trying to give more importance to, called the Nipah virus. So whether it's real scare or do we need to really worry about, or is it going to cause a severe pandemic like the COVID virus? We are very uncertain about it, but probably let's have a discussion. And if at all, we need to be ready to face it at any point of time. Nipah virus, now just looking into the history now, how did the name come from Nipah? Where did it come from? It first originated in 1998 and 1919 in Malaysia and Singapore. So, and especially in a village called Sungai Nipah, that's where the name Nipah was given, because in that village, a person was affected, and in that person, that virus was first isolated, and hence the name Nipah came from the name of the village called Sungai Nipah in Malaysia. As you all know, the first outbreak occurred in Malaysia and Singapore in 1998 to 99, where the pig was the amplifying force and was the main culprit behind this disease actually. And India, now we are more worried about, because we have developed in India of last 3 years, we have been seeing some few cases, especially in Kerala. But what the first outbreak in India developed in Siliguri district in West Bengal in the year 2001, where 66 cases are reported. But again, the most important aspect that needs to be notified here is the child, it had a very high mortality rate, and especially most of the people who are affected are mostly healthcare workers who are trying to help the infected people. And in fact, the healthcare workers were affected, and there were a high mortality rate even amongst the healthcare workers. So that is where probably this virus carries more significance than the present COVID virus. In the year 2007, 50 people were infected in the Nadia district bordering Bangladesh. But since the year 2007, every year in Bangladesh, there are always few epidemics occurring almost every year, some few cases occurring. In 2018, between the months of May to 18 cases in Kozhikode was the first epidemic in Kerala, actually, where the fruit bats was the main reservoir. And almost 8 out of 18 cases, 17 cases have expired. So it had a very high mortality rate. And last year, 2020, we had one positive case. A 22-year-old boy was affected, but he recovered. And here now, we are here talking about this topic because of a one positive case, which was detected on September 5, a 12-year-old boy who unfortunately expired because of the complications of Nipah virus. Now, looking at the epidemiology, now Nipah virus, it's a highly pathogenic RNA virus of the family Paramyxovirus and belonging to the genus Henipavirus. The natural reservoirs are the fruit bats, nothing but the flying fox of Pteropus genus. It's called a Pteropodidae family. So the fruit bats are the main natural reservoirs, but how are we getting it from to the humans? How is it carried to the humans? It's mostly, especially in the first outbreak in Malaysia, where the pig was the main source of infection to the humans, where if a pig is an amplifying host, how do they get infected? They get infected after consumption of a partially bat-eaten fruits or raw date palm juice contaminated with saliva and urine of bats, actually. So either pig is an amplifying source, or directly consumption of juices or partially bat-eaten fruits directly by the humans, which has been contaminated with the saliva and urine of the infected bats, which carrying the virus, probably human infections can occur. And so far in the seasonality, especially in the outbreaks which had occurred in Bangladesh and India, most of the outbreaks occurred during the months of winter to spring, especially between the December to May, actually. But of course, this year we have developed a little later in the month of September, but of course, clear cut, there is no specific seasonality. Maybe winter to spring, probably the bats are more common. So that could be one reason attributed to the seasonality between December to May. And what is the incubation period? Incubation period can be as short as 4 days and maybe can be as long as 45 days. But generally they say 4 to 21 days, but it can be as long as 45 days. There is no clear-cut evidence or study to suggest the period for which a patient will shed the virus in different body fluids if they are infected. But maximum, as long as 45 days, still they can carry the virus in the secretions. What is the mode of transmission? I mean, probably as we are told, the main natural reservoir is infected bats, actually. So transmission to humans may occur either after direct contact with infected bats or the infected pigs or from other Nipah virus infected people. So one, direct contact with the bats, or the other contact with pigs, or human to human transmission. The first outbreak occurred from human infection resulted from direct contact, where many of the people were infected when they were dealing with the sick pigs or the contaminated tissues or the pig secretions, actually. So it occurred via unprotected exposure to the secretions of the sick animals or unprotected contact with the tissue of a sick animal. But India outbreak, the conception of, mostly it occurred initial outbreak, especially in West Bengal, it occurred because of consumption or consumption of fruit products, raw date palm juices, which was infected with urine or saliva from the infected bats. So human to human transmission through close contact with people's secretion, excretion, that's where mostly health workers were affected in the initial outbreaks, actually, where people were, either the contacts or the healthcare workers were looking after the infected patient. So this is a diagrammatic representation how is it transmitted. Natural hosts fruit bats, either from fruit bats to pigs or from fruit bats directly to animals or pigs to animals, and from human to human transmission. What is the pathogenesis? Even though it has been more than 20 years old, the disease has been the first onset, but still the exact pathogenic mechanism is not clearly documented. Because again, unlike most of the viral illnesses, nobody has a clear-cut idea what exactly is happening in this disease. But what are the theories that have been proved is it primarily involves the blood vessels still, like as we all talking about in coronavirus, that vasculitis and vasculopathy, this Nipah virus also primarily involves the blood vessels, namely in the form of vasculopathy or necrotizing vasculitis, resulting in either perivascular cellular infiltration, inflammation, and necrosis of the tissues. And probably because of the due to high viremia and increased viral load, probably one aspect is cytokine storm or several chemokines are released which are causing the vascular damage. The severity of the disease dependent on the extent of vascular damage. And some cases show the postmortem examination showed gross cerebral and pulmonary edema. Even cross-section of the brain and lungs showed gross pulmonary hemorrhage and cerebral congestion. So probably the major disease involvement with which had caused a high fatality rate is probably the involvement of the brain or the involvement of the pulmonary involvement and probably involvement of cardiac tissue also. So what are the clinical features? Mainly the incubation period is 4 to 21 days, which can be as long as 45 days, which I told you prior. But like similar to other virus illnesses, in majority of the patients, it is asymptomatic. Almost 50% of the individuals are asymptomatic, similar to like other viral illnesses. And some, they develop just a minor upper respiratory infections like fever, cough, cold, or coryza. So they are all very non-specific symptoms initially, which may present as fever, headache, dizziness, vomiting, like any other viral illnesses, which doesn't give any clue to the specific nature of this disease. But of course, certain hallmark of the Nipah virus infection is the acute onset of the following symptoms, namely, it can be moderate to high-grade fever, or it can be headache, or it can be associated with severe vomiting. They can have sore throat and cough, breathlessness, and sometimes they can present in an altered sensorium, probably due to the neurological involvement, like changes in behavioral changes and altered sensorium. They can manifest as seizures or status epilepticus with abnormal involuntary movements, and again a non-specific symptom like myalgia, fatigue, very common in viral infections. See, most common, as I told you, is asymptomatic with the minor upper respiratory infections, but they can also present with the severe respiratory infection, where they can present as atypical pneumonia, sometimes with tachypnea or dyspnea, or sometimes even the breathlessness that often progresses rapidly, resulting in overt respiratory failure. But most commonly, we have come across is the acute onset of the neurological symptoms, which were mainly headache, unaltered sensorium, and seizures from the third day of onset of illness. Almost 30 to 40% of the person presented either it can be a generalized seizures or a focal seizures, but more commonly focal seizures, like similarly seen in any viral encephalitis. Again, like similar to other viral encephalitis, behavioral changes were also present, where often one of the initial presenting features even before development of an altered sensorium or unconsciousness. So probably even any changes in behavioral patterns without any symptoms of headache, vomiting, or seizures, probably think in terms of a viral encephalitis due to the Nipah virus. The most important point is in a significant number of patients, the disease rapidly progressed to coma within 5 to 7 days actually. So probably that is where before we could come to identify or probably determine the onset of the illness, the patient goes in for most of the complications, and probably sometimes we are not able to save the patient actually. So few patients also developed myocarditis, heart failure, and pulmonary edema, often associated with or without cardiogenic shock. So one probably this year, the 12-year-old child presented with both encephalitis as well as myocarditis. So not only neurological involvement, not only pulmonary involvement, even cardiac involvement in the form of myocarditis or heart failure should also be always thought in terms of a Nipah virus infections. Coagulopathy may be seen in some of the cases with probably a raised D-dimer also. So these are some of the symptom presentations where they have an acute onset presentations, probably suspect a viral encephalitis, then probably our viral myocarditis or acute respiratory distress syndrome. Always, like other viral infections, probably think in mind also Nipah virus too. Of course, one complications which I've seen, probably psychiatric complications may be seen after full recovery. There's one more entity called late onset encephalitis, which might occur 10 weeks after the initial exposure to a patient or the causative agent. So probably where there are initially no features, probably after 10 weeks, we call it as a late onset encephalitis. Still, we need to rule out Nipah virus infection. What are the common physical findings actually? So these are the major symptomatic presentations, like any specific common viral illnesses, all symptoms, they do not have any Nipah virus, do not have any specific symptoms saying this is particularly characteristic of a Nipah virus, but unless other viral infections, they all have similar symptomatologies. Now, what are the physical findings? Like again, any other viral infections, fever is generally persists for 3 to 4 days, might be high grade and even may persist for 5 to 7 days too. Tachycardia and tachypnea were noted and progressed to overt respiratory distress with oxygen desaturation. So probably the child present with breathlessness, they may rapidly progress to acute respiratory distress syndrome or pulmonary edema and respiratory failure. So always we need to be more alert in treating these patients. At presentation, most of the patients have normal blood pressure. There are no specific rashes or petechial rashes or any other rashes in the body. There's no bleeding spots or no hemorrhagic spots from any sites. And systemic examination usually does not show any significant abnormalities. For example, there's no specific organomegaly except a mild hepatomegaly, which might be seen in some other cases, but except in case of respiratory involvement where they can present with pulmonary edema, where you might get a bilateral crepitations or tachypnea, dyspnea with low saturation. So other than that, none of the systemic examination is contributory to Nipah virus infections. Most of the disease, the process, there is often evidence of a gradual fall in hemodynamic parameters with failure of respiratory cardiac compensatory mechanism evolving into state of respiratory incontinence. So always that ABC, airway, breathing and circulation, need to be always monitored. So whenever the patient is probably having a high grade fever with any of the suspected symptom, always the patient should be kept in an isolation ward or in an ICU to monitor the further progression of the disease, and if at all needs to be immediately taken care. The child may be conscious, the patient may be conscious level, could vary from a fully alert or sometimes they may become deeply unconscious and they may go in for a deep coma too. And features of encephalitis or a few cases of meningoencephalitis may be present on second or third illness. So probably encephalitis or meningoencephalitis may be the initial presentation of the Nipah virus itself. So probably that it might be too late or it might be a little difficult to treat those patients. Unlike another meningeal bacterial meningitis or a viral meningitis or TB meningitis, then generally we don't see much of signs of meningeal irritation or neck stiffness or any other meningeal signs may not be present among these patients because they more commonly present as encephalitis rather than a meningitis. Of course, another neurological symptoms, they might be in a state of altered sensorium present. They might be stuporous, disoriented, and as I told you, behavioral abnormality, they may become aggressive or maybe too comatose too. And of course, I told you systemic examination may be a mild hepatomegaly. Any wellness nut can present with a mild hepatomegaly, attendance may be noted. And suppose other organ involvement, probably like hepatic involvement or renal involvement, generally not routinely seen in the initial state of the disease, but they can go in for a multi-organ involvement where renal failure can also be documented in the later stages. And multiple other organ failure is also noted in the severe stages of this. So always need to have a look of about the other organ involvement too. Now, how to come to a diagnosis actually, so I'm not going to talk about in detail about, because routinely we do for any viral illnesses like a routine blood investigations, like a complete blood count and CRP probably to rule out other infections. But specifically when the child presents with a viral encephalitis, now what is the commonly thing we do? Initially we look for is do a lumbar puncture, we look for a cerebrospinal fluid analysis where it showed the typical of a viral pattern where lymphocytic pleocytosis with elevated protein count and normal glucose content. And probably planning to do an MRI if the child is stable, if MRI brain features suggestive of disseminated small signal hyperintensities, best seen on FLAR sequences predominantly involving the white matter actually. So these are all the non-specific investigations, of course, which doesn't give any particular specific clue to the Nipah virus. But of course, the most important is the identification of the NAV RNA virus either by RT-PCR or antibodies against NAV in the serum or CSF or isolation of NAV from the secretion. So what best investigation is to do an RT-PCR testing to detect the RNA of the NAV virus from either from the respiratory secretions or from the urine or cerebrospinal fluid, or isolation of the virus itself from respiratory secretions, urine or cerebrospinal fluid or other tissue specimens, only to be carried out on a biosafety level because this contains a highly contagious organism. So BSL-4 laboratory needs to be done. IgM antibody against NAV identified in serum or CSF, IgM or IgG antibody just indicates, IgM indicates the acute phase, or IgG indicates a prior NIV infection. Of course, other investigations are not particularly characteristic of Nipah virus infection. The only characteristic finding is the RT-PCR testing and IgM ELISA or virus isolation from the culture study. And when do we collect these samples actually? So how do we suspect and probably when do we collect it? Samples should be collected as early as possible, preferably within 4 days with all biosafety precautions. Wear complete disposable personal protective equipment. Of course, now we are all very much aware, probably after this corona pandemic, how to use a personal protective equipment. So especially in Nipah virus, the use of PPE is more mandatory because it is even more contagious than the present COVID infection. So wash hands with soap and water for at least 30 seconds, and then clean the hand using 1 to 2 ml alcohol-based hand sanitizer before and after collection of samples. Usage of personal protective equipment, I mean like probably the gowns and the gloves, mask, and proper covering the entire bodies with shoes and everything. So proper PPE and disposable PPE should be used, especially before collecting the sample. And what are the samples that needs to be collected? That mainly is the throat swab sample is collected in a vital transport medium. And
5 more minutes, sir.
Yeah, sure. And probably a blood sample and CSF at least 1 ml in a sterile container. So these are the samples that needs to be collected. And more importantly, after the collection of samples, the transport becomes the biggest issue because it should be safely packed in a triple container packing and should be transported under the cold chain maintaining at 2 to 8 degrees centigrade. How do we collect it? First, disinfect the outer surface of the container using 1:100 dilution of bleach or 5% Lysol solution. Sample should be kept in good quality plastic bags tied with rubber bands. And the plastic bag should be kept in another container sealed with the adhesive tape. And this carrier should also be kept in a plastic bag. So there should be 3-layered bag, and finally kept it in a carrier containing ice. And it should reach the laboratory where it is done in our country, India's National Institute of Virology, Pune. Within 48 hours of collection of sample, it should be sent to the NIV Institute. Or if it takes more than 48 hours, the sample should be sent using dry ice. How do you go about to the management? It's just a symptomatic and supportive treatment, maintain the airway, breathing, and circulation. And most importantly, please isolate the patient in a separate room or ward, and separate nursing and staff should be allotted, and separate doctors should be allotted to take care of those patients alone. Institute a barrier nursing, wear a proper PPE like mask, gloves, gowns, shoe covers, and of course, hand washing with soap and water. What are the other supportive treatments? Drink plenty of fluids. Just maintain the fluid maintenance and electrolyte balance. And adequate maintain the NG tube feeding or parenteral nutrition if necessary. And oxygen, probably depending on the level of saturation if needed, and mechanical ventilation. And oropharyngeal or endotracheal suction should be done using a closed circuit, and especially to avoid the disposal of aerosol and prevent further infection transmission. And usage of anticonvulsants for seizures or mannitol for intracranial tensions, and of course other supportive drugs if the child has got a cardiogenic shock or shock vasopressors. Of course, there's no role for antibiotics or steroids unless and until if there's a secondary bacterial infection, then there is a need for antibiotics or prolonged ventilator support. There is a role for antibiotic, but routinely antibiotics as a first-line drug is not indicated. Role of ribavirin. Ribavirin was used initially in the first epidemic, especially in the Malaysian outbreak, where it is, even though it's not a proven drug, but was generally used. They found the benefit was significant with 36% reduction in mortality, and the side effects was less actually, but still the efficacy is not clearly proven actually. And when do we discharge a patient? They can be discharged only after full recovery and RT-PCR becomes negative. Even after discharge them, advise them home isolation till 21 days after the date of the illness. The most important thing is the case fatality rate is 40 to 75%. Now, what are other newer drug probably still under evaluation is we are trying that to use immunotherapeutic treatments where especially monoclonal antibody therapies are currently on development and evaluation. One such monoclonal antibody is M102.4 has completed phase 1 clinical trial, but still it's a long due for to be used in a routine drug actually. Now, of course, there have been trials, especially after this COVID, especially now in the present area where they have been in Kerala, the government have tried using remdesivir and favipiravir. Remdesivir has been effective in non-human primates when given as post-exposure prophylaxis and can be complementary to immunomodulated drugs. But probably they are trying to people who are infective and who are NIV positive, not probably as a not with contacts or negative people. But favipiravir, they have been given to people, especially the boy who had died. Actually, the favipiravir was given to contact of the which the boy had with, and especially, and of course, they have tried it, and most of them haven't developed any unusual symptoms, but still the role is not clearly proven. But of course, always for any disease, prevention is always better than cure. Even though currently there are no vaccines available against Nipah virus, but still there have been a lot of studies going on. One study on vaccines probably focused on the effectiveness of Jado XL. It's a multi-purpose vaccine vector that can be customized to carry DNA from a wide variety of pathogens, but still it has been tried in the primates. Still a lot of time needed to probably to be used in the humans actually. Of course, controlling Nipah virus in pigs and reducing the risk of infection in people, probably from host animals to the humans, probably, or reducing the risk of bat to human transmission, maybe probably the bat contaminated fruits and fruit juice, probably sterilized one, reducing the risk of animal to human transmission, namely, or reducing the risk of human to human transmission. This is the most important thing, reducing the risk of human to human transmission, because one person gets infected, probably the lot of healthcare workers whom they need to take care of themselves, and of course reducing the risk in healthcare settings actually. So all the healthcare workers and the contacts of the person, they need to be much more protected, probably in order to prevent them from getting infected. So what are the key messages? It's an emerging zoonosis, does not need to be notified till date, but should be reported. Cases range from asymptomatic to those involving fatal encephalitis with a highly pathogenic virus with a case fatality rate of 45 to 70%. Because one good thing is, even though unfortunately, one 12-year-old boy died, actually, the contacts so far, so they all have tested negative. So that is a good news, actually. So the Nipah virus care in Kerala seems to be under control. But as long as there's a lot we don't know about this virus, the possibility of epidemic can't be ruled out. So probably we still need to have a more study on all these things and probably have a better drug to combat the infections. So hopefully we don't suffer with Nipah virus as we have been suffering with coronavirus. Thank you all.
Thank you, sir, for highlighting us about Nipah virus.
Thank you, sir, for the very engaging and informative lecture. Sir, I have a few questions which I want to ask. We'll quickly go through them, sir. One is about, because after we came to know about COVID, we knew that it is milder in children, and the proportion of asymptomatic infections in the first and second waves are also higher in children. So does this virus also follow such a pattern that it is mild in children, or we don't have enough data to comment on that now?
Honestly speaking, we don't have enough data because actually this is the first time we had seen a 12-year-old boy died of the Nipah virus this year, actually a 12-year-old boy. But if you had looked into the previous outbreaks, it has been mostly the adults, and even last year, one 22-year-old male was affected actually. So we don't have enough data about regarding the severity of children and severity of Nipah virus in children. So probably still this disease is a question mark whether it will severely affect the children or not. Actually.
So far only one child was affected by this, and he's dead. Right?
Yeah.
All right. So the next question is: do the personal protective equipment precautions followed by us for with respect to coronavirus hold true in Nipah virus prevention as well, sir, or is it different?
No. It is the same actually. No, see, we are all of us. We are not aware of personal protective equipment. Still, we all had to encounter directly with the COVID positive patients actually. So, in fact, more than the COVID positive patients, because it is even dealing with the handling the secretion itself. Of course, coronavirus, it was more of an airborne transmission. Even we touch the secretions, most of them we didn't have. Still, we are not clear whether it will be infections or affected. But here, the Nipah virus infection, the secretions of a particular individual or the excretions of a particular individual, or responsible of human-to-human transmission. So there's a strict usage of personal protective equipments definitely is indicated more than we use in coronavirus.
So both contact as well as aerosol and droplet prevention is more important.
Definitely. Yeah.
Right, sir. So among treatment options in those who have been cured of the disease, has anything been used and found to be successful, sir?
No, no, it's similar to it. So that's what it's like the viral encephalitis. Actually, there's no specific drug which had been given and found that this is the effective treatment or the drug of choice in these patients. Like any other viral encephalitis, probably we are just giving supportive therapy and just keeping a look whether the child is recovering spontaneously or not. That is a problem. Nobody has a clear idea what is the drug of choice and what needs to be given. We are just treating symptomatically.
Right. So in that child who was only a pediatric case of Nipah, I think everything was tried, sir. Favipiravir, Ribavirin, and everything, right, sir?
Yeah, probably, this remdesivir, favipiravir, probably because they have used it because probably viral and people have had enough experiences in the usage in COVID positive patients. So probably that is the reason I think they would have tried that option also, but still whether it was effective or not, or whether it is going to be effective or not, we are still uncertain about it.
All right, sir. So I think there are no more questions. So thank you, sir. Thank you for the time, and sorry for holding you up, sir. I know you have an obligation.
No. Thank you very much.
Thank you, sir. Over to Jyotsna for the next session.
Thank you, sir. I next invite Dr. Muthaiya, sir, consultant pediatric intensivist, to give us a talk on the rational use of vasoactives in shock. Over to you, sir.
Thank you. I'll just share my screen. Good evening, one and all. Thank you for this opportunity to discuss the rational use of vasoactives in children. It's more of a practical approach. I've tried to give a little bit of basics followed by case-based discussion how to practically use inotropes in children. So, as far as the overview of the talk will be when to use vasoactives in pediatric shock, which one is preferred where, what is the working dose range for optimal effects with minimum side effects, what is the present evidence, and due to the paucity of studies and data, we rely only on experience and available evidence. Monitoring, weaning strategies, and other supports will also be, I'll be trying to discuss them. So, this is about circulatory shock, not some other shock. So it's about circulatory shock. DO2 versus VO2 mismatch is the basic pathophysiology. That is oxygen delivery versus oxygen consumption mismatch. Either there is poor reduced delivery or increased consumption, not meeting the tissue demands. So there is inadequate tissue perfusion to provide adequate oxygen and to remove the metabolic base. The early signs of any shock being tachycardia, tachypnea, poor skin perfusion with mottling or delayed capillary refill, altered sensorium, and oliguria. So the treatment for most of the shocks are basically fluids with or without vasoactives. I'll go through some important formulas which are important to understand shock. Sorry for bothering you, but this slide is important. We were talking just about delivery of oxygen. That is equal to cardiac output multiplied by arterial oxygen content. So there should be enough oxygen in the blood and the blood flow should be adequate. So the heart should pump well, and the blood should flow and reach the tissues with adequate oxygen in them. So cardiac output being heart rate multiplied by stroke volume. So we all know in infants they are having a rate dependent cardiac output. So cardiac like heart rate is also equally important. But very high heart rates are harmful because they compromise diastolic myocardial perfusion. Stroke volume being governed by preload, contractility, and afterload. Here, looking at the arterial oxygen content, they are mainly governed by the hemoglobin level multiplied by 1.34 because each gram of hemoglobin carries 1.34 ml of oxygen, multiplied by saturation of oxygen, that is the oxygen bound to hemoglobin, plus the TaO2, that is dissolved oxygen, partial pressure of dissolved oxygen, multiplied by 0.003. So we all know that the dissolved oxygen doesn't play a major role. It's mainly the oxygen saturation and the hemoglobin levels. Another important formula which we have to remember is oxygen extraction ratio. That is the ratio of DO2 divided by DO2. That is basically there is a delivery of oxygen to the tissues, and the tissues utilize some oxygen and return back some to the systemic blood flow to the RA. Sorry. So that is the oxygen content, the superior vena caval oxygen content, or you can say the that is a surrogate for VO2. That is VO2 divided by DO2. We can calculate these things individually. Ultimately, it comes to arterial oxygen content minus venous oxygen content divided by the arterial oxygen content. Blood pressure, shock is synonymous to blood pressure, right? We always think shock means low BP, but yeah, blood pressure is important, and the formula for that is cardiac output multiplied by systemic vascular resistance. There is a minimum systolic BP target for the 5th centile, that is 70 millimeter plus age into 2, which we all do remember. What is more important, more than the systolic BP or the actual mean arterial pressure, it is the perfusion pressure. Perfusion pressure is equivalent to mean arterial pressure minus central venous pressure, and the acceptable perfusion pressure for various ages are 55 plus age into 2 millimeter of mercury. So we always try to target perfusion pressure, which is a better better target or goal in shock. So we understand all these governs the shock pathophysiology, and the optimizing these parameters will be the primary and the only goal in various shocks. So I would like to compare Ohm's law. We would have all learned in physics Ohm's law to the analogy in circulation. That is, one second. U divided by I is equal to resistance. That is, voltage divided by flow will be equal to resistance. What do they mean is, for the electric current to pass from one place to another, you need a certain potential difference or the voltage difference, and the flow itself is determined by the resistance to the current flow. So similarly, when we see this perfusion pressure is nothing but something similar to the voltage, the potential difference, MAP minus the CVP, the pressure gradient, divided by the cardiac output, which is equivalent to flow. And we all know the cardiac output as well as the perfusion pressure is always governed by the resistance offered by the circuit, that is the systemic vascular resistance. So otherwise, we can say the pressure or the perfusion pressure is dependent on both the flow and the resistance in the circulatory system. So it all comes down to this, you see. we see BP, why BP is equal to cardiac output multiplied by systemic vascular resistance. This is the thing. So pressure is equal to flow multiplied by resistance. So that's how this formula comes. I just thought it's important to understand this. Now coming to the topic. What's the problem with just giving fluids? We know shock is there. We can give fluids and we can correct the shock, right? Why do we have to think about inotropes? And especially the concepts in fluids have changed in the last decade after the FEAST trial. So fluids correct hypovolemia, but not hypoperfusion. So we must be carefully using fluids just to optimize preload because too much fluid is harmful. And fluids also doesn't stay where it has to stay longer. Whether it is crystalloids or colloids, in a sick child with increased vascular permeability, how much ever fluid you give, it's going to leak away. So it's not going to ultimately improve the perfusion. It may transiently improve, but the long-lasting effects may not be there. Too rapid fluid boluses are harmful. Because when you give too rapid fluid bolus, there is a quick fall in the sympathetically mediated circulatory compensation. Any shock state, there will be sympathetic overdrive, and the patient tries to compensate. On giving too much fluid bolus, it suddenly blunts the sympathetic response, which is bad, and also increases the risk of ischemic reperfusion injury. Also, by giving too much of a fluid bolus, we also have a risk of unmasking the underlying myocardial dysfunction seen in many shock states, especially septic shock. Also, it worsens endothelial dysfunction by altering the microvascular permeability, and most of them, they have a procoagulant state, and this leads to not only leak but also clot. So the perfusion ultimately gets impaired. Positive fluid balance is harmful in critically ill children. Not only in the acute stage, also the recovery itself delays in children who are fluid overloaded, and it can cause even mortality. So we need to understand fluid responsiveness, the static and dynamic parameters, and fluid tolerability. So the thing on fluid is any child who's hypovolemic needs fluid, but at the same time, you need to have fluid targets, check fluid responsiveness, and at the same time, a child who is fluid responsive need not be fluid tolerable. That is, you give there is a good response to fluid, but when you give fluids, there are more negative effects rather than the positive effects. That is, you're having more extravascular lung water, you're getting more ascites after giving a fluid challenge, which is harmful. You're going to cause more myocardial dysfunction as well. So that's why we need to use inotropes or vasoactives. When to use? All sorts of fluid refractory shock except hypovolemic shock. So hypovolemic shock, fluid alone is enough, but all other sorts of fluid refractory shock, after fluid resuscitation, if shock signs are persistent, and if fluid alone is not able to correct the perfusion, we need to use vasoactives. So what are the available options we have? Dopamine, the age-old dopamine, which is seldom used nowadays, with a dose range of 3 to 20, but we prefer to use only 5 to 10 mics per kg per minute wherever we, especially in resource-limited settings, still it can be used. The clinical effect of it being inotropic action, as well as vasoconstriction at higher doses, and also it is a chronotrope. It can increase the heart rate as well and the peripheral vascular resistance at higher doses. The concern with dopamine is it has a higher risk of tachyarrhythmias, and immune suppression has been noted in adults. Sometimes it also causes splanchnic vasodilation, which can reduce perfusion to vital organs. Dobutamine, which is the second drug, dose range being 1 to 20, but the commonly used range is 5 to 10 mics per kg per minute. We never go beyond 10 mics per kg per minute nowadays. and it's predominantly having a beta action. So it is having it is an inodilator. It has an inotropic action as well as a vasodilatory action, and it decreases the peripheral vascular resistance. The concerns with dobutamine are it causes more tachycardia, and it increases the oxygen consumption of the heart. So we need to be understanding this while using it. Epinephrine dose range is 0.01 to 1 mg per kg per minute. At lower doses, it has beta action. At higher doses, it has alpha action. Higher doses being above 0.3. So usually we use anywhere between 0.05 to 0.3. We seldom go above that. Clinical effect being anatropy, chronotropy, and vasoconstriction. The problem with the epinephrine is tachycardia, gut hyperperfusion, hyperglycemia, and increased lactate because of the glucose shunt. Norepinephrine is also commonly used for warm shock states. The dose range being 0.01 to 1 mg per kg per minute. It is predominantly an alpha action, very minimal beta action. It predominantly causes vasoconstriction. It increases the systemic vascular resistance, and it also is a inotrope. Has a very minimal beta 1 action at a very high dose, so which we never use actually. So the dose range commonly used here is 0.05 to again 0.3. Anything above 0.3 mg is considered high dose for norepinephrine. The concerns again, mainly it causes gut hyperperfusion because of intense vasoconstriction at higher doses. Phenylephrine rarely used in cases where we want only vasoconstriction, only we have a pure vasoplegic state. Milrinone is again an inodilator. Dose is between 0.25 to 1 mg per kg per minute. The usual dose range is anywhere between 0.25 to 0.75 mg per kg per minute. Very rarely a loading dose is used for milrinone, especially post bypass in cardiac OTs. And the mechanism of action, it is a type 3 phosphodiesterase inhibitor. It is an inodilator, inotropic as well as a vasodilator action. It also increases the heart rate at higher doses. The problem also being higher risk of tachyarrhythmias. The beneficial effect of milrinone is it has a lucitrophic action. That is, it causes diastolic relaxation of the heart, especially the right heart. So it is quite useful in conditions where you have a high pulmonary vascular resistance and associated right heart failure when you have a combined problem. So that is the advantage of milrinone, and it doesn't increase the cardiac oxygen consumption like dobutamine. But the problem is it has a longer half-life. Most of these drugs, dopa, dobuta, epinephrine, norepinephrine, have very short half-lives. You know, dopamine, dobutamine have a half-life of 5 minutes. Epinephrine, norepinephrine have a half-life of 1 minute. But milrinone has a half-life of say 2 to 3 hours. So there, the effects may be longer. Being an inodilator, it may cause even a bad hypotension. So that is another issue with milrinone. We need to be careful. If the patient develops hypotension, we need to be careful, and we should be ready with a fluid, a small fluid challenge. And vasopressin is the next drug which we rarely use again for vasoplegic states. The dose ranges 0.0003 to 0.002 units per kg per minute. It acts through the vasopressin 1 receptor by binding to that. It is a different mode of action. It is not a catecholamine based drug. It also causes vasoconstriction. The advantage is although it causes vasoconstriction elsewhere, it improves the perfusion to the brain as well as it reduces the pulmonary vascular resistance. So in pulmonary hypertension as well as raised ICP, vasopressin is beneficial. Also in catecholamine resistant states, like with severe metabolic acidosis, where catecholamines don't work, like epinephrine or norepinephrine, vasopressin may help. And it also is useful in pulmonary hypertension situation. Milrinone is also equally good in pulmonary hypertension. Other drug which we rarely use is the calcium as an inotrope, very rarely used, purely in cardiac setting, and levosimendan. Levosimendan is also increasingly being used. It is also an inodilator. It binds to the troponin C and the calcium sensing receptor, and increases the extracellular calcium in the heart, thereby improving inotropy. And it is also kind of an inodilator. Half-life is very long, so it is called as a weekly inotrope. Half-life, they say it can even last, effects can last even up to 1 week. Again, the problem is hypotension. The dose range is usually 0.1 to 0.2 mics per kg per minute. Levosimendan is also increasingly used in cardiac settings, and it also doesn't increase cardiac oxygen consumption. And the tachyarrhythmia risk, which we see with milrinone and dovitamin, is very much less with levosimendan. So the types of shock, just now we saw the inotropes and vasoactives available to use. Sometimes we also use vasodilators, rarely, like nitroprusside or glyceryl trinitrate. As a vasodilator, rarely when you have a purely vasoconstricted state, which we commonly don't use, at least in pediatrics. Hypovolemia is the commonest type of shock associated with GI or skin or urine losses. Their fluid resuscitation alone will help. Cardiogenic shock, it could be due to arrhythmias or myocardial dysfunction secondary to a congenital heart disease, septicemia, or cardiomyopathy or myocarditis. Here, their fluid should be restrictively used, and we advocate early inotrope use, like inotropes like adrenaline, dovitamin, milrinone can be used with early respiratory support when it is progressing. Distributive shock, again, septic shock is the most common type, followed by anaphylaxis or neurogenic shock secondary to spinal cord injury. Here again, fluid boluses are first tried. If fluid refractory, we need to use early inotrope, adrenaline or noradrenaline, depending on the hemodynamics. Obstructive shock is very rare, but it is important to identify that, because in case if you miss that, you will be, it won't reverse basically. So here, fluids, obviously any shock are knee-jerk reflexes to give fluids, but in obstructive shock, which is secondary to a air leak or a congenital cardiac disease with duct-dependent circulation, duct-dependent systemic circulation, or a cardiac tamponade or a pulmonary embolism. All these are causes of obstructive shock. Depending on the clinical status, we need to identify and relieve the obstruction with ICD or a tamponade relief by a pericardial tapping, or in duct-dependent circulation cases, we can use PGE1, prostaglandin E1, to or atrial septostomy to open the obstruction and to cause a right to left shunt. So how do you monitor shock? There are upstream and downstream markers, that is macro circulation, what we see in drowns, which we can at least measure and see. They are heart rate, urine output, the pulse volume, so-called peripheral pulse volume, central and peripheral pulses, the sensorium of the child, target pulse pressure, which is
sorry to interrupt,
CBP.
sir. 5 more minutes left.
Oh, sorry, I've taken too much of time. Will I get extra 5 minutes?
Sir, you will get 5 more minutes, sir.
Okay, sure. Thank you. Thank you, Jim. So, strain echo, cardiac output monitors can be done, bedside echoes. Microcirculation markers will be SCVO2, lactate, peripheral perfusion index, NIRS, CO2 gap, gastric tonometry, sublingual microcirculation, video capillary microscopy. Always monitors are helpful, but close monitoring of the clinical condition, progression of the primary illness for which the shock has happened, the sequential organ failure score or pediatric logistic organ dysfunction score, which should be monitored in serial intervals, are important to monitor, and based on which we can wean off inotropes and other supports. How do we wean? First in, first out, or last in, first out is what is commonly practiced. But what I would say is taper all vasoactives to safe dose limits. If you have a higher dose for one inotrope, you try to come down to a safer limit. And once you've reached the safe limit for all the 2 inotropes or 3 inotropes which you have used, then titrate based on the hemodynamics. That will be the best approach. So, just a moment. Yeah, this is the strain echocardiography. It identifies subclinical LV dysfunction. This is the non-invasive cardiac output monitor, flow track, and this is the icon, which is again non-invasive. We can identify the cardiac output, extravascular lung water, and systemic vascular resistance, and so on and so forth. This is the sublingual video microscopy, the indirect dark field microscopy, which shows you more recruitment of capillaries as shock improves. And this is the NIRS, which is regional oxygenation, which is also a very good non-invasive tool to monitor oxygenation. I'll skip this for want of time because, yeah, what are the do's and don'ts in vasoactive use? Polytherapy is better than going on escalating one drug. Ventilate if requiring more than 2 vasoactives to maintain perfusion. That is early invasive ventilation if we require more inotropes. Know the interactions between drugs and use them synergistically. The commonly used combinations are adrenaline plus noradrenaline, adrenaline plus milrinone. Adrenaline noradrenaline is for septicemia, adrenaline milrinone for cardiac causes, noradrenaline vasopressin, pure neurogenic or warm shocks, noradrenaline milrinone also for a mixed setting. Always check line patency, proper dilution, and so that we make sure the proper drug dose is safely delivered to the patient. Always establish central line whenever needed for higher doses because that is a safe way of administering vasoactives. Rule out or correct or treat anemia. In acute phase, hemodynamically unstable, hemoglobin of 10 is advocated. And in hemodynamically stable children, hemoglobin of 7 is advocated by septic shock guidelines. Occult air leak, thrombus, drug-dependent circulation should be identified and treated because their vasoactives won't work. Do not wait for a central line to start vasoactives, which is a common mistake. We can very well start inotropes in peripheral line. Don't wait for organ dysfunction worsening to start vasoactives. Don't mix 2 vasoactives in one infusion pump or syringe pump and give. That may cause a lot of issues. Don't give higher doses in peripheral line. It may cause extravasation and other issues. So for want of time, I'm not going to discuss in detail about these cases, just going to give you an overview. This is a 5-year-old boy who had all features of septic shock. You can see he's having a tachycardia, hypotension, received 2 fluid boluses, was started on inotrope also, 0.1 mg per kg per minute of adrenaline. And he had a low EF and invasive BP was showing wide pulse pressure, but he was having a cold peripheries. So, and lactate was high, procal was high, and he had significant organ dysfunction also at admission. This child was managed with fluid boluses, followed by vasoactive support. He required adrenaline up to 0.4, noradrenaline up to 0.3. So, and ultimately, he also landed up in AKI and had to be started on RRT along with antibiotics, and the blood culture grew MRSA. This is the classical septicemia, septic shock. So how do you treat these septic shocks? Whenever you have a cold shock, the traditional teaching is cold and warm shock. Although now we all know that the definition of cold and warm shock itself is arbitrary, but still for discussion, we can use that. Cold shock are those states where you have a low cardiac output, vasoconstricted state with a high systemic vascular resistance, where adrenaline is the first inotrope of choice. And warm shocks are states where you have a hyperdynamic circulation, like a flush capillary refill time, high cardiac output state with a vasodilatation and a low SVR, where the first choice will be noradrenaline. But it is not so easy just to feel the pulse and say this is cold, or periphery this is cold and this is warm. Why? Because they can be the same patient, when we do invasive monitoring and see the SVR, they may have different. The cold shock may be actually a warm shock, and a warm shock may actually become a cold shock. And the same patient may have both cold and warm at different time points. That is the challenge. So when there is after resuscitation, when there is after adrenaline in cold shock, when there is normal BP but still poor perfusion, we need to consider inodilators like dobutamine, milrinone, and levosimendan. And if there is low BP with poor perfusion, then you consider adding noradrenaline or giving a volume. Again, here the SCVO2 will be below 70 in both the conditions because of poor perfusion. If you have SCVO2, it's better to measure. And here, SCVO2 for that, we need a IJV line. Basically, we need a internal jugular vein sitting between the RA SVC junction. So if you have that, always worth measuring the SCVO2 in the blood case. Here, in warm shock after adding noradrenaline, if the shock still persists, low BP with poor perfusion, we can increase noradrenaline or add vasopressin. So that's what I was talking about. The swing between cold to warm shock and vice versa in the same patient at different time points. How it is possible? Like in this patient, like he had a low SVR presenting with cold shock. He had low SVR, right? 90 by 28 was the invasive BP. Inadequate fluid resuscitation and underlying, because of inadequate fluid resuscitation and underlying myocardial dysfunction, they will have cold peripheries. Once you volume resuscitate them and start a targeted inotrope, that is when the stroke volume improves and it unmasks the warm vasodilatory state. Similarly, high SVR can present as warm shock. Like this is a very common presentation in pediatric septic shock. Fluid resuscitation is being given, and because of fluid resuscitation being the child is being started on noradrenaline, because the peripheries are warm. Early septic shock, we give fluid resuscitation and start on noradrenaline because of warm peripheries. Once the fluid bolus, I told you, right, it can be harmful with the underlying myocardial dysfunction, and NORAD increases the SVR and puts more afterload on the heart, thereby worsening the myocardial dysfunction, and the stroke volume worsens and unmasks the cold shock. So this is the reason why we don't use the terminology as warm and cold shock. We basically see the physiology and treat. The second one is a classical dengue child, not going into details. Dengue NS1 positive, acute febrile phase, day 5 critical illness, coming with a platelet count of 25,000. In shock, hypotensive BP 70/40 for a 5-year-old. Received 20 ml per kg bolus and shifted. Still found to be in shock. Signs of poor perfusion, weak peripheral pulses. Child is dull, pale looking with a normal sensorium, though with cold extremities. In PSU, we gave another 5 ml per kg. And since already 25 ml per kg was given, this being a dengue shock, we also gave a 5 ml per kg of 5% albumin. And also did a bedside echo, which showed a EF of 35%, which was not expected on day 5 at least, with only 20 ml per kg. Mind you, she has not received any fluid boluses outside. So you can see the echo finding here showing global LV hypokinesia with a EF of around 35%. And again here, we can see we have filled the patient. We think we have filled the patient with 30 ml per kg, but you can compare the IVC with iota. This is the IVC. I'll play it again. This is the IVC, which is small. Always we compare IVC to iota. And this is the iota. Iota is bigger than IVC, and IVC is small. It is collapsible and it is small. So here, what is the what do we do now? So mostly in dengue shock after fluid resuscitation, one of these 5 scenarios can happen. This being a dengue season, I just wanted to highlight this point. When IVC is post fluid resuscitation, when IVC is full and LV ejection fraction is normalized and perfusion is better, we just go to conservative fluid maintenance and monitor for worsening. This is good scenario, best scenario possible. If IVC is small and LV ejection fraction is normal and perfusion is better, IVC is not full, but it is still small, you continue full maintenance fluids. Monitor for fluid leak or shock features in the critical phase. If IVC is small, ejection fraction is normal, and you have signs of poor perfusion, then consider more fluid challenges, monitoring the tolerability, early use of colloids. These patients benefit best with colloids because of higher returnability, like albumin, 5% albumin or gelfusin. And also they may benefit with low dose adrenaline with continued monitoring. What happens with this? This is the last 2 are rare scenarios and harmful ones, bad ones. IVC is full and LV ejection fraction is poor, but the perfusion seems to have improved. Here, you just stop further fluid boluses, reduce fluids to 70% maintenance, consider adrenal infusion in poor perfusion cases, or Lasix infusion if signs of fluid overload is there, based on the day of illness and the PCB and other findings. And early intubation will help in these scenarios where you have a full IVC and poor LVEF, but perfusion is okay. And the last and the most dangerous scenario is you have given a lot of fluids, IVC is still small, LV ejection fraction has also become poor, and the perfusion overall has become very poor, or still continues to be poor. Here, Still, fluids need to be administered. Here, early inotropic initiation is also advised. Mechanical ventilation is also to be done early. And based on the ongoing fluid requirement, to decide on kidney replacement therapy like peritoneal dialysis or CRRT based on the available facilities. Because here, ongoing fluid needs are there. So cautiously giving and removing is required. So this is what we practice in our unit, and this is what works for us. Coming to like last case, this is actually a traumatic brain injury. Child with motor vehicle accident with who came unresponsive posturing to ER with a low GCS, got intubated, had all features of raised ICP in CT also, had come with shock, received fluid boluses, and due to poor like map around just around 5th centile even after fluid boluses, we need to start vasoactives, because in for neuroprotection and traumatic brain injury, we try to maintain a map around 50th to 90th centile. Here the vasoactive of choice will be noradrenaline. Although the child had cold extremities, when we do the invasive BP monitoring, we know it is still a wide pulse pressure and a low SVR shock. And cold extremities could be due to hypothermia and in number of reasons. This is the last child again. This is a MISC child who was a 12-year-old, came with hypotensive shock on day 5 of fever, had cardiac involvement with an EF of 45%. Here again, fluid bolus has been given, followed by simultaneous adrenaline infusion since there was hypotension. Again, here the child had cold extremities, but since he had a cardiac dysfunction and still he had a kind of a wide pulse pressure, we don't use noradrenaline. Since there is a ejection fraction issue, it's always better to go with adrenaline followed by the after the fluid bolus, because starting noradrenaline may put more load on the failing heart. So as far as cardiogenic shock presentations in general pediatric practice, it could be warm, dry, warm, wet, cold, dry, cold, wet. So as we move towards bedside, the pulmonary capillary wedge pressure increases and there is more congestion features. As we move from warm to dry, the cardiac output reduces and we have cardiogenic shock features from failure to cardiogenic shock. That is, there is oxygen depth. So managing warm and dry is the easiest scenario. You just give oral medicines, they should be okay. Warm and wet, you need to start diuretics as well and vasodilators as well. And they might be monitored in ward, like a VSD child coming with LRTI and CHF, associated congestive cardiac failure. The other two bottom ones are rare and they have to be managed in the ICU. And they usually have low cardiac output state, as well as they don't have congestion features, cold and dry. Here we have a scope of giving fluids as well as titrating inotropes to improve perfusion. The last one is is again a very bad physiology, where you have cold perfusion peripheries as well as a low as well as you have congestive features. That is, they are already wet. There is a significant bilateral crepitations or lung signs along with low cardiac output state. Here, early inotropes, early mechanical ventilation, or sometimes even mechanical circulatory support is advocated if vasoactives alone fail. Mechanical circulatory support most commonly is IABP or ECMO. So my conclusion will be hypotension is a late and obvious finding in children who are in shock. So we need to pick up early. Optimal fluid resuscitation, timely initiation of vasoactive support to achieve therapeutic targets, followed by early targeted resuscitation. That is, initially give fluids, then try to maintain neutral balance or negative balance in late phases of shock. Focus on individual physiology and the setting in which the patient is being treated. That is, titrated inotropes for each individual based on the physiology. Epinephrine is gaining momentum over dopamine as the first-line inotrope in sepsis and most of the pediatric shock states. There are two pediatric shock studies. For want of time, I didn't mention. Venturi et al. And Karthik et al., both in PCCM 2015 and 2017. Both have showed early shock reversal with epinephrine compared to dopamine. And one study even showed epinephrine leads to lesser number of days in ICU, lesser number of mechanical ventilation, lesser number of mechanical ventilation days. That is, ventilator-free days are more with epinephrine. So early shock reversal, lesser number of days in ICU with epinephrine. And another recent study showed equivalent. It was a non-superiority trial. Both were having equal effects. Point of care ultrasound plays a major inevitable role. Multimodal monitoring should be used wisely so that they guide rather than misguiding the physician. Too much of monitoring is also harmful. So use them diligently based on the patient physiology. Patients in shock don't deteriorate suddenly. Most of the time, shock is identified suddenly. Thank you for the opportunity. Sorry for over exceeding the time. Thank you.
Thank you, sir, for that amazing talk. We have few questions.
I think Jyotsna, we'll just limit to 1 or 2 questions because Sir has answered mostly all the questions very comprehensive in the slide. Professor Nedunjelian Sir has asked when you're not able to delineate the type of shock, which inotrope would be safe and effective, and probably that one, Sir, if you can reiterate, probably it would be epinephrine, right?
Yes. If we don't know the type of shock, always the safest inotrope is epinephrine. And also we're going to monitor. When we don't know the type of shock, we have to be more careful, and we need to image these patients. Like bedside ultrasound that plays a major role. We can find out like occult air leaks and all. When we can't, because most of the time, based on the clinical history, we will be able to at least have an idea what kind of shock it is. But otherwise, the safest one will be epinephrine, low dose epinephrine.
Right, sir. Thank you. And I think you've already provided an algorithm for selection and continuation with dengue as an example, very extensively provided. One last question before you wind up the session. Is there additional benefit of exceeding 10 microgram per kg of dobutamine? Why we don't exceed more than 10 when the range is up to 20?
Dobutamine. For both dopamine and dobutamine, we don't go above 10 because above 10 mics per kg per minute in dobutamine, it causes more tachycardia and tachyarrhythmia. Basically, dobutamine is used in cardiogenic shocks, where we want to have we want to limit the heart rate. When heart rate goes high, the diastolic time for the heart, the myocardial perfusion itself reduces. And because of this, the oxygen consumption by the myocardium increases, which we don't want. So at doses above 10 mics, it becomes more of a chronotrop rather than an inodilator. Dobutamine is commonly used for increasing the contractility and reducing the afterload. But when we use above 10 mics, the added effect of chronotrop reduces the myocardial oxygen perfusion and increases the consumption. And increasing the heart rate can compromise the perfusion also. That is the reason we don't go above 10 mics. And I think but the dose range is up to 20.
Right, sir. Thanks for the very nice explanation. Thank you, sir.
Thank you.
We'll move to the next talk, which is by me. So I'll take the liberty from Jyotsna to start the presentation quickly. So Jyotsna, is my slide visible and I'm audible, right?
Yes, sir.
I guess so, yeah. So I'll quickly start. We don't have much time, but this is a topic which is of practical importance. I'll quickly run through the slides, and this is about newer anti-epileptic drugs, principles and practice. So what are the ideal properties for any anti-epileptic drug? So generally we want a broad spectrum drug, which, if you don't know what the seizure semiology is, we can just put it and the patient gets cured or has decreased number of seizures. So it has high efficacy, good tolerability. That is the most important thing, because anti-seizure medications, usually parents are afraid of side effects. No allergies, which this group of drugs is very notorious for. And you don't have any interactions, that is pharmacokinetic, so that the dosage is easy, no metabolic interactions with other drugs, and it's low cost, and there is no need for intensive lab monitoring, and the levels do not fluctuate, and has a wide therapeutic window. So all these are desires more than what really happens. But what are the three most important things are that we need a drug with high efficacy, good tolerability, and no risk of allergic or idiosyncratic. Dose-dependent side effects, it's always tolerated. We can reduce the dose and get away with them. But idiosyncratic reactions are always a problem. So these ideal properties are always never met, like that of an ideal gas or an ideal disinfectant. We do not have an ideal anti-epileptics. So that led people to search for newer anti-epileptics, because older anti-epileptics had lots of side effects. So they found a host of newer antiepileptics, which are described here under the heads of narrow spectrum and broad spectrum. But what we have found out that they're only equally effective, not more effective than the older ones. But the good thing is that the drug interactions and tolerability is very good. So that is the only advantage probably of the newer antiepileptics. And one disadvantage in apart from that being only equally effective and not more effective is that they're expensive, way more expensive than the cheaper ones, the cheaper good old phenytoin, phenobarbital, and carbamazepine. So there are narrow spectrum ones and broad spectrum ones. So only some of these are narrow spectrum, like those of oxcarbazepine, vigabatrin, lacosamide, and broad spectrum drugs include a host of drugs, including lamotrigine, levetiracetam, topiramate, zonisamide, and the rest. So we'll be discussing briefly one. So the question is, are newer antiepileptic drugs safe and always more efficacious? I tried to answer this previously as well. Newer drugs score over the older drugs in terms of tolerability, safety, improved pharmacokinetics, and lower drug-drug interactions, but efficacy may not be significantly higher, and most of the times rather lower than conventional AEDs. You may see that the good old phenytoin and phenobarbital are much effective in controlling seizures than the newer, fancier ones, which we are happy to use, but we don't see very great results. So this is not a, this is just a generalization. There are usefulness, there is specific usefulness of certain drugs too, which I'll be elaborating in the later slide. So the first generation drugs, we are all aware. One drug which has been found among the older ones to has been found to be useful nowadays, and is probably the drug of choice for absence epilepsy, is ethosuximide. I'll be discussing that. And the second generation drugs are a host of ones, but levetiracetam, vigabatrin, lacosamide, lamotrigine, oxcarbazepine. So these are the things which I've chosen to discuss. So that's why I've highlighted it in them in red. And among the third generation drugs, most of them we don't use: perampanel, eslicarbazepine, and retigabine, which is not which has been taken out from the market. So brivaracetam is the one of the third generation drugs which is probably finding a new use these days. So I'll be discussing these drugs in detail after I discuss from some slides on the basic principles. So one can see that the good old drugs, carbamazepine, oxcarbazepine, and phenytoin are all sodium channel blockers. And in addition to clobazam and barbiturates being potentiation of GABA activity by increasing the frequency of channel opening or the duration of channel opening. So the older drugs had only a few or narrow mechanisms of action, whereas the newer drugs are exploring newer targets, such as glutamate antagonists. You know, glutamate is a excitatory neurotransmitter. So lamotrigine and topiramate act on various glutamate receptors. And you have the calcium channel blockers, among which ethosuximide, lamotrigine, and zonisamide. Among these, the last two are newer ones. And you have levetiracetam, which has a totally different mechanism of action. It acts on the neurotransmitter release from the nerve terminal. That is, it blocks the synaptic vesicle 2A protein, which prevents neurotransmitter release. So these are the new targets which are used. Which is kind of new because these targets have not been explored previously. But unfortunately, we are just the only benefit of these newer drugs, as previously mentioned in those slides, are that they are useful in avoiding the side effects, and they're good with multiple drugs. That is, when you put patients on polytherapy, unlike phenytoin or carbamazepine, which induce the metabolism of other drugs, they don't do. But efficacy-wise, not a great margin has been achieved by these newer drugs. So how effective are these as add-on versus placebo? So there are two uses of antiepileptics, the newer ones. One, you stop the older one and substitute it as a standalone or a single agent, that is monotherapy. The second is for refractory epilepsy, use it as an add-on. So as an add-on, it has only comparable efficacy to older standard drugs. None of the newer AEDs is superior to the older drugs in terms of seizure remission. So if you add probably lamotrigine or topiramate to a child with refractory focal seizures, it is as effective as adding probably phenytoin to a combination of probably valproate or phenobarbital. Right? The additional efficacy of newer AEDs when used as add-on in refractory epilepsy compared to placebo are disappointingly small. But what is the use as monotherapy? So there is limited data as monotherapy because when the child is controlled on one drug, we continue on it. When the child is not controlled on one drug, we shift it to another drug, probably in the older group as well. So newer therapies were not studied for monotherapy. So newer drugs, but one drug which has shot up in prevalence in popularity is oxcarbazepine in focal epilepsy. It is considered to be the drug of choice for focal seizures. Another one is vigabatrin in infantile spasm, which is probably a specific use in this condition. So other drugs which have been used but do not have much evidence is levetiracetam and lamotrigine. Ironically, we use levetiracetam very commonly as a loading drug and use it as a standalone or monotherapy, but the evidence supporting this is poor. And in practical experience, we see that levetiracetam as a monotherapy always is suboptimal. So what is the current status of newer AEDs versus conventional AEDs in focal epilepsy? So I'm just going to spend a few slides on the specific type of epilepsy. So the first point, we see whether it is a focal seizure or a generalized seizure, and then categorize whether it is a part of focal epilepsy or generalized epilepsy syndrome. So basically, none of the newer AEDs were superior in efficacy to carbamazepine. So carbamazepine and phenytoin are the drugs of choice for among the older agents in focal seizures. So studies have shown that all the newer agents, including lamotrigine, oxcarbazepine, and all these were just non-inferior in efficacy. So they can be as efficacious as the older drug, the prototype of which is carbamazepine, but they are not superior to them. So carbamazepine was reported to be more efficacious when compared to the other less efficacious drugs, including topiramate and gabapentin. So the older ones are as good as the newer ones, or to state it otherwise, the newer ones are as good as older ones, but not great. So in generalized epilepsy, you can see still older ones are better. Valproate is the drug of choice for generalized epilepsy. So we generally say that valproate is more efficacious than lamotrigine, and studies have proven that it is even more efficacious than topiramate. So I'll just discuss few drugs, among which ethosuximide is one. It is considered the drug of choice for absence. It is not truly a newer anti-epileptic. It has found its use by the newer generation of neurologists, because it is a relatively safe drug and has a very good efficacy when compared to valproate or lamotrigine for absence seizures. So only thing you have to know then is that in the child with absence seizures, is a host of drugs, particularly sodium channel blockers such as carbamazepine and phenytoin, is to be avoided. So the first thing is do no harm. If you don't know what the type of seizure is, better refer to a neurologist. Don't commit yourself to giving phenytoin for a child with absence epilepsy. That will only worsen the seizures and probably have a cognitive effect as well. So this is a study which shows that valproate is useful only in certain conditions when the absence seizures are associated with generalized seizures also. So in that particular instance, you will use a drug which is which has a broad spectrum. Otherwise, only when there is absence seizures, then ethosuximide is a good choice. So ethosuximide and valproate have higher efficacy. Among the three drugs, probably ethosuximide is the best, followed by valproate, because valproate has been shown to have attention and cognitive side effects in children who have been followed up in the long term. So again, this slide shows that children on ethosuximide, if the children on ethosuximide still do not have complete remission of absence seizures, then addition to a polytherapy of valproate plus ethosuximide is useful. So a combination is much better than a monotherapy. So when a child does not respond to ethosuximide alone, do not substitute it with valproate unless he has different kind of seizures, such as myoclonic seizures or generalized tonic-clonic seizures. Then probably single valproate would be good. But if it is only absence not responding to ethosuximide, then use a combination. So combination is better. And the second AED is ineffective. So first AED is ineffective, use a combination. Coming to levetiracetam, levetiracetam is a new drug, but we are using it much more commonly than the older drug, mainly because it has a very good side effect profile and it does not have any interactions. It is easy to administer. You can quickly give it by the IV route. You can even push it over 15 minutes, but that's not widely practiced or recommended. So it has 100% bioavailability. It is as good given orally as well as IV. So there is no monitoring required and no hepatic metabolism. It is very, very good drug, but it is not as efficacious as the older one. That is the ironical truth. So it's a novel mechanism of action. As I told you, it has synaptic vesicle blocking action, and it has several atypical electrophysiological actions, such as it has GABA, calcium, and calcium channel modulating effects also. But only one thing you have to remember it is that it has a synaptic vesicle blocking action, which is unique among all the anti-epileptic drugs. So only in hepatic involvement, only when it is severe, you'll think of dose alterations. In renal impairment, you need not do any dose alterations. And as contrary to what is believed previously, it is not a drug devoid of side effects. You see more aggression, agitation, especially in pubertal age group, and you see in children with intellectual disability and all kinds of developmental disorders, including autism. They can have very severe behavioral problems. The main thing is that we load levetiracetam. Anything more than 40 milligram per kg definitely will cause some degree of CNS side effects, including behavioral problems, ataxia, irritability. And that is one of the reasons prolonging hospital stay, which you have seen in practice. So generally have thumb rule that more than 40 milligram per kg, it's not more efficacious, it only has more side effects. So the practice of loading 60, 80 and 100 nal per kg should be discouraged. And in long term also, we can have these adverse effects. So that is very important to monitor these patients for behavioral side effects. So it is useful for all kinds of seizures, very broad spectrum. GTCS, myoclonus absence is useful for any kind of epilepsy or any kind of syndrome. But the behavioral side effects is very, very important. And in severe liver dysfunction or renal dysfunction, only in the severe spectrum, you need to do a dose modifications. Generally, it is good for all comorbid conditions. Next comes brivaracetam, which is a newer generation of this. So brivaracetam is useful even in patients who do not respond to levetiracetam. So that is one advantage. The other advantage is that brivaracetam has a slightly different mechanism of action, and it has a better side effect profile. That is the neuropsychiatric side effects which I mentioned: irritability, aggression. In bigger children, suicidal thoughts are all lesser with this. But only thing is that it has some drug-drug interaction with other drugs, so it has to be careful. Always initiate at a lower dose. 0.5 milligram per kg is a better starting dose rather than 1 milligram per kg, and slowly titrate. Whereas levetiracetam has an advantage of quick titration, higher dose and all that. So these are the added advantage of brivaracetam over levetiracetam. And it's important and fascinating that it is useful in patients who have not responded to levetiracetam, though the mechanism of action is only slightly different. Overall, the mechanism of action is the same, but somehow this has an effect on patients who do not respond to levetiracetam. So adverse effects are the same. One, you should remember that there is hypersensitivity added to the list. So bronchospasm and angioedema can be there. So you should remember this as an additional adverse effect. But overall, these neuropsychiatric adverse effects when compared to levetiracetam is less. Coming to oxcarbazepine, again, this is not a really new drug, but it has found its use in patients with focal epilepsy. It's a drug of choice these days. When compared to carbamazepine, it has nearly a great side effect profile. So you have no drug interactions, nearly no drug interactions, and no autoinduction of own metabolism, which is a main problem with carbamazepine. So it has it's a sodium channel blocker. So sodium channel blocking is a very basic anti-epileptic mechanism of action among the first generation drugs. So it is useful for focal seizures as well as generalized seizures, but generally used for only focal seizures. Neurological side effects in very high dose only it causes dizziness. So generally there is no problem with these drugs is what I would say. So the theoretical side effects are hyponatremia, which is theoretically much more than carbamazepine, but probably we have not seen this even despite very prominent and widespread use. One thing you should advise patients is that there is a risk of rash, but when compared to phenytoin, carbamazepine, and all the aromatic drugs, the OX modification of carbazepine is called oxcarbazepine. So this chemical change decreases the chance of a skin rash. So skin rash or the Stevens-Johnson syndrome is lesser. The prevalence is the incidence is lesser, but nevertheless you'll have to warn patients and ask them to stop the drug immediately if they develop a rash. So the primary indications, as I told you, it is an adjunctive therapy for monotherapy. So can very comfortably used as monotherapy for partial seizures. That is, previously it was known as partial seizures. Now it is known as focal seizures, and it is very good in its side effect profile as well as efficacy. So the dose is not the point of discussion, so I'll skip this. Coming to lacosamide is found interest because it is available as an IV preparation, and though it is a sodium channel blocker, it has a unique mechanism of action that it enhances slow inactivation. All the older drugs which act on sodium channels block the sodium channel in the fast state. So this blocks the sodium channel in the slow inactivated state. So that is different. So you can give it with other sodium channel blockers as well, because it truly has a different mechanism of action. Though it acts on the same sodium channel, it has a different mechanism of action. So it is very good because it can be given IV. So it has found popularity in the emergency and the PICU setting. So it has 100% bioavailability. You can just convert it to orally also at discharge. So that is very important. And more importantly, just like levetiracetam, no drug-drug interactions, no significant dose reduction except for very severe hepatic or renal dysfunction. And as I told you, intravenous formulation is available. So it is a very good side effect profile, but it is more useful in focal seizures. In very small children, we don't have evidence, but still we use them. It is useful as an add-on rather than a standalone or a single agent, that is monotherapy. So dosing, we not worry about this, but this is a drug where you can even give higher doses. It's not a problem. Like levetiracetam, it is very dose friendly for practicing pediatricians. Coming to vigabatrin, vigabatrin was approved in 2009. It is not available in India. It is always, brought into India through illegal means. But it has found a very useful and an effective indication in treatment of epileptic spasms, previously known as infantile spasms, in one specific condition called tuberous sclerosis. It's a drug of choice in that condition. It also does not have much of adverse effects. You need not worry about drug-drug interactions as well, because most of it is excreted unchanged in the urine. So the most important side effect at higher doses is sedation. So always start slowly and start with a lower dose. And you can have psychiatric and neurologic effects in high doses. It can lead to an encephalopathy, acute encephalopathy, where there are significant MRI changes. And only thing you need to monitor in children is visual field examination every 3 months. So at high doses given for more than 6 to 9 months, it can cause visual dysfunction. Generally, we limit it to not more than 9 months in practice. Availability and cost is a prohibitive factor. That is the most important thing. As I told you, it is useful in spasms. It is a drug of choice, or the first drug to be used in tuberous sclerosis with spasms. In certain patients with other causes of infantile spasms, like hypoxic ischemic encephalopathy, who do not respond to steroids, we use it as a second-line drug. In addition to that, it is used for focal epilepsy as well. In addition to all the other drugs we have told you, oxcarbazepine, lacosamide, levetiracetam, this can also be used, but its efficacy is not very great in those conditions. The only prohibiting factor in that is, in this drug, is cost. A strip of 10 tablets, I guess, cost 2,000 rupees. So it is very cost prohibitive. So that is only disadvantage probably. Lamotrigine, quickly I'll go through. It is once again a useful drug in that it does not have lots of CNS side effects. Though it is listed, it does not have lots of CNS side effects. The only problem with this drug is that it has significant drug-drug interactions, especially with valproate, and it has a high propensity to cause rash. So just like the aromatic drugs like phenobarbital, phenytoin, there is a 10 to 12% prevalence, which is really great, but most of the rash occurs in the first 4 to 8 weeks. And you can, at the first appearance of the rash, if you stop these drugs and quickly, take care of the patient and start IVIG or something when the child has a clinically diagnosed to be SJS or TEN, you can always save the child. So it is always important to go slow when you start with valproate. That is the most significant adverse effect. So this drug-drug interaction is very, very important. When you use with valproate, if you start a high dose or even a routine dose of lamotrigine, you can have devastating side effects, that is Stevens-Johnson syndrome. So generally we go for a very, very low dose. You can see that monotherapy, you start it as 0.3, and while with valproate, you start it even at half dose. So you could go very slowly. With enzyme-inducing effects, probably you can, enzyme-inducing drugs such as phenobarbital or phenytoin, probably you can start at a higher dose, but generally we go for a lower dose. You should remember with valproate, you should always be careful for drug-drug interactions. It is again broad-spectrum antibiotic and anti-epileptic drugs. You can use it for focal as well as generalized seizures, and many epileptic syndromes are compatible with these drugs. So this is one slide which shows the other two drugs which I have not discussed in detail in addition to lamotrigine. So these drugs are generally can be used in all kinds of seizures, both focal and generalized. And it is important that these drugs are monitored for side effects. Some drugs have specific side effects, such as topiramate and zonisamide have a predisposition to have metabolic acidosis. They can result in renal stones. They can have serious CNS side effects, such as dizziness, when compared to lamotrigine, which does not cause such side effects, and cognitive changes in the long term. And another important thing with zonisamide and topiramate is Stevens-Johnson syndrome, in addition to lamotrigine, which I've already mentioned. So dehydration and all can lead to heat pyrexia and heat stroke also, because they have problems with renal regulation of water as well as peripheral regulation of temperature. So this is very important with zonisamide and topiramate. And topiramate can cause a condition called acute hyperammonemic encephalopathy when combined with, especially with valproate. So both these drugs are notorious for this complication. You should always monitor. So the efficacy and the use and indications are all the same, but the side effects are different. So that is what you have to remember, particularly with zonisamide and topiramate. Renal stones and weight loss are important side effects, and lamotrigine, I told you about the allergy. So what are the drug-drug interactions? I've already told you. Zonisamide has significant interactions because it is activates through, it is metabolized through the CYP3A4 dependent metabolic pathway. But the other drugs generally don't have lots of side effects, except for one drug which I've already mentioned, lamotrigine, especially with valproate. So other drugs generally don't have a problem. this zonisamide is one exception. Other than that, probably topiramate is a drug which does not have much drug-drug interactions. So that is, and I've talked about levetrestam and oxcarbazepine. So drug-drug interaction-wise and safety-wise, it is okay. But efficacy-wise, as I told you, the bottom line is that there is not much advantage when compared to the older drugs. So lamotrigine requires slow titration, should importantly with valproate, I already told you, and topiramate and hyperammonemia I've already mentioned. So this is very important. You should not think that AEDs are devoid of side effects. We have certain specific side effects, just like visual field effects for vigabatrin, the Stevens-Johnson syndrome for lamotrigine, and rufinamide is not used here. So it can cause short QT interval, and lacosamide can cause prolonged PR interval. So these are two cardiac side effect drugs we should remember, and the hyporammonemic encephalopathy has already been reiterated by me. So this is one nice question which can appear as a question or can be remembered very easily. Most of the drugs can cause weight gain in the first generation drugs. The carbamazepine, like valproate, is very notorious for weight gain. Even phenytoin causes coarsening of facial features and some weight gain. But the second generation or the newer ones generally cause weight loss, including topiramate and zonisamide. But there is only one drug which causes, felbamate is another first-line agent which is used along with phenobarbital and the drugs of that class. It also causes the same side effects as them. But there is one drug which causes weight gain, and that is vigabatrin. Just like valproate, you can remember 2 V's which cause weight gain. And topiramate and zonisamide, I told you, it can cause low urolithiasis. Hence, we recommend lots of water in those patients and weight loss. So always you should remember that you should choose a drug according to the patient, because efficacy wise, you don't have a great margin with the newer drugs. So you're choosing them because you want to avoid the side effects of the previously used intolerable side effects of phenytoin or valproate or something like that. So you should choose the patient, the drug according to the patient profile. If a patient is an obese patient, it will be a good option to choose topiramate or zonisamide. If you give valproate or any of even oxcarbazepine in higher doses can cause weight gain. So in those patients, if you choose such a drug, then it will cause a problem. And you should always remember that levetrestam in high doses cause neuropsychiatric side effects. So that is very important. And in addition to that, topiramate also, I told you, to a certain extent, zonisamide also can cause cognitive side effects. So lamotrigine is one which is free, relatively free of cognitive side effects. So that is one drug which can use. Only thing is that the allergy and the thing which I've already mentioned. So which are the most successful ones? Levetrestam and topiramate are the most successful ones. It's very evident after this discussion because they have very least drug-drug interactions, very limited side effects apart from the other ones. And they are generally broad spectrum. You can use it with any drug combination. So this one combination is very useful, but you have to be very careful, valproate and lamotrigine, because there is increase in the blood levels of lamotrigine with valproate. So you should always use it in a slow rising titration. But generally, generalized seizures which are not managed with valproate alone usually benefit from a combination of lamotrigine and levetrestam. Similarly, levetrestam with valproate or levetrestam with lamotrigine is useful, particularly in focal seizures. Levetrestam and lamotrigine is a useful combination. So these combinations have proven to be successful. The other combinations are very random in its effect. So availability is a big problem. We have some black market preparations also, as I told you. So these are all drugs which are used abroad, like bromides are used commonly in Europe, rufinamide also in Europe, steripental in the US and UK, but you don't get these drugs very commonly here. So cost is also prohibitive. As I told you, vigabatrin is smuggled into India through many other means because it is useful for, especially for tuberous sclerosis patients with spasms. So 10 tablets cost 2,000 rupees. It's cost prohibitive for our kind of a socioeconomic build. So lacosamide itself costs 140, lamotrigine 10 tablets 65. We will be shocked when you know that one strip of phenobarbital or one strip of phenytoin or one strip of sodium valproate costs less than 1/3 of what these drugs cost. So that is one thing which is prohibited, because we're looking at 2 or 3 or even 5 years of antibiotic drug therapy, which adds a huge monthly burden in these children. So this is my last slide. So I thank everyone for the opportunity given to me, and I think I finished on time. So the past was intuitive medicine. That is, you think the patient has this problem and you think this drug works and you start giving. The present is based on evidence-based medicine. You can quote all the trials which I previously quoted, that ethosuximide is useful in valproate. It took some time for people to accept that ethosuximide is the first line. Previously, people were using valproate and are happy with the response. And only when the older drug was then repurposed and started to be used in absence epilepsy, then people said that, okay, the evidence suggests that, so probably we'll use it as first line. Now it has established its role as firmly as the first line drug. So that is clinical trials. In the future, we'll have precision medicine. So precision medicine, one example is vigabatrin, because it is the drug which is used only for specific indication for tuberous sclerosis. Another example is everolimus, which is a rapamycin inhibitor, that is mTOR pathway inhibitor, which is used because of the only specific mechanism of action, that mTOR pathway is upregulated in tuberous sclerosis. So in the tubers, the pathway is upregulated, and the upregulation of that pathway leads to seizure. So if you just target that as a precision measure, you can control seizures in those patients, and it's found to be very effective. So in the future, we'll get much more such mutations as genetics expands. For one specific mutation in one particular patient, probably we'll find that this particular drug or this particular combination is effective, and therein lies the true use of these newer drugs, which are many in number. So I thank everyone for the opportunity and stop presenting. I think Jyotsna and Sabrita, we don't have any questions, I guess. So I have tried to
Dr. Shivan,
the important points. Sir, yes, sir.
Will monitoring drug levels help in the management?
Right, sir. So overall, sir, the answer to this question is no, it is not very effective. But certain conditions, it is effective in that probably in certain kinds of epilepsies which are very responsive to sodium channel blockers. Like there are certain mutations like the SCN2A or SCN8A genetic epilepsies, where phenytoin and carbamazepine or oxcarbazepine or other sodium channel blockers are the only source of respite or treatment. So in those patients, we sometimes give a supratherapeutic dose also. So in those patients, we do serial monitoring of drug levels, and that will be helpful. Other than that, in those specific conditions, and in one particular condition, which I would say is we suspect toxicity more than efficacy. When we suspect drug toxicity in a child who's encephalopathic after status epilepticus, the child has prolonged encephalopathy, and we don't know what is causing this encephalopathy, we suspect it to be overloading of phenytoin. We have a practice of giving boluses, mini boluses, and few more boluses. Then we find that the phenytoin level is toxic. We get it somewhere around 40 nanogram per ml, which is twice the recommended range. 10 to 20 is a normal level. So then it is useful. So for these two specific indications, it's useful. Other than that, doing a valproate level, doing a phenytoin level and a phenobarbital level to monitor efficacy is not very effective because there is no linear relationship between the drug levels and the efficacy also. And phenytoin, the drug like phenytoin has very variable pharmacokinetics. So many times we have a child with well-controlled seizures and do a phenytoin level, it is something around 4 or 3 or 2. So it's very difficult to believe in such patients as well. So these are the two indications I could think of, sir.
Thank you, Dr. Shivan. Thank you.
Thank you.
So one last question, sir.
Yes, Jyotsna.
For newborn age groups, sir, like the AEDs that we can use from these groups?
Yeah, that's a nice question. Because newborns, it is still, Jyotsna, we stick to the older ones because we do not have much efficacy or safety data for the newer preparations. So one exception would be levetrestam, which has been studied relatively extensively in newborns and has been shown to be effective. Some people use levetrestam as probably the second or even the third line, but unlike pediatrics, we have shifted to levetrestam as the first line. Newborns, we do not have that much data from evidence platforms to suggest that. Other drugs are used anecdotally in cases of neonatal status epilepticus. We generally we use lacosamide. There are some reports of using topiramate, but these are all not evidence-based. So I think phenobarbital, phenytoin, levetrestam, these are the 3 drugs which we generally use. And if they're refractory, we go for pyridoxine, and we think of other non-pharmacological measures to control the status epilepticus. We don't go for other drugs, but still anecdotal case reports are there for usage of nearly all drugs anecdotally in the newborn period.
Thank you, sir. I think we've reached the One more question.
Yeah, I was just reading it. Up to what age group phenobarbital is a first line drug in GTCS? Okay. So generally in the newborn period, we use phenobarbital. Away from the newborn period, I think phenytoin should be a good choice as a first line agent. And smaller children generally have a good tolerability for the adverse effects of phenobarbital. Phenobarbital is a very highly sedating drug. So newborns even tolerate very high doses, even beyond or up to 5 milligram per kg. Whereas in bigger children, even a small dose of somewhere around 3 milligram per kg can be very sedating. So that is one thing which is to be remembered. But generally beyond 1 month, phenytoin. Some pediatric units practice beyond 3 months. They go for phenytoin, and up till that they use phenobarbital. That is also acceptable, I guess. But generally we use more than 1 month. Outside the newborn intensive care unit, we use phenytoin as a first choice. I think we'll wind up, right?
Thank you, sir.
Okay. Yeah, so I'll thank everyone for your attention. I thank all the senior pediatricians. Dr. Thangavelu sir and Dr. Gauri Shankar sir could not join us. They wanted to be here. I thank Professor Nedunjelian sir and Professor Annamalai Vijayaraghavan sir for joining us, Kannan sir for this for approving this session and staying with us. I also thank all the other faculty in Mehta and the postgraduates, and special thanks to Dr. Jyotsna and Dr. Sabrita for coordinating the session and making it a success. I also thank all the speakers, the delegates, all the 5 other faculty who gave very clear and useful talks. And for the participants, it's available in our YouTube channel, in the Mehta Pediatric Neurology YouTube channel. You can go check it out and see those, listen to those lectures and see the slides again at your leisure time. So thanks everyone. Meet you at another opportunity. Thanks and good night.
Thank you, Dr.
Thank you, sir.
Thank you, sir.